Hello, everyone. Good afternoon, or depending on where you are in the country, good morning. And thank you for joining us both in person here today and online for this event focused on identifying the challenges and building on the successes to date and accelerating the adoption of accountable care in Medicare. Today's event will provide some opportunities to reflect on what's happened so far with accountable care reforms and opportunities to leverage new administrative proposals and legislative proposals in Congress to build on progress to date, both in the near term as we head into 2025 and beyond. With that in mind, we're here today to look back, but especially to look forward on key issues related to accountable care in the United States. CMS, under the last two successive administrations, has set a goal of giving all Medicare beneficiaries and the vast majority of Medicaid beneficiaries access to accountable care relationships, defined as care that is coordinated, longitudinal, and enables affordable and timely access. It's been called people first care as an alternative to the fee for service care that is often fragmented, expensive, and can lead to worse outcomes, higher costs, and greater health disparities. So, where are we now? Well, we'll talk about that. But to provide some context, in traditional Medicare, more than 13 million beneficiaries are in accountable arrangements today, including the Shared Savings Program, at the Center for Medicare that provides care to almost 11 million Medicare beneficiaries. And CMS has created additional on-ramps through the Innovation Center, like the Making Care Primary pilot for Safety Net and other providers that have been reluctant or unable to join accountable care arrangements to date. Medicare Advantage, the private plans in Medicare that are accountable for total spending and for some health outcomes, now enroll almost over half of beneficiaries. And within that group, almost half are receiving care from accountable providers, too. More whole person disease specific models, like for dementia and for kidney care, are being developed and implemented. And models like value based insurance design in Medicare Advantage are also expanding. The Innovation Center at CMS has altogether tested over 50 different reform pilots, and these have led to a clearer core chassis for accountable care, built around person-based payments and overall cost accountability for advanced primary care practice, with additional payment reforms, data sharing, and other steps to further advance coordinated whole person care. This chassis is now widely used, as I mentioned, in the traditional Medicare program, particularly the Shared Savings Program, Medicare's main ACO program, so that it isn't really an alternative payment system to fee for service, but more of a standard approach today. At the same time, participation in accountable care models in traditional Medicare has been growing slowly and is definitely not on pace for the goal of all Medicare beneficiaries having access to accountable care by 2030. And along with that, concerns about whether these steps are realizing sufficient savings and care improvements have also been the subject of a lot of congressional and advocacy debates. Providers continue as well to face challenges heading into 2025, including statutory physician payment reductions under the MACRA law, strains on the workforce, and tight budgets that limit their ability to make new investments to succeed in accountable care reforms, perhaps making the status quo more attractive than reform despite the challenges of the status quo. This is especially true for healthcare organizations that seemingly too often have been on the front lines in public health emergencies, like responding to the short and long-term catastrophic damage caused in parts of the country just this past week by Hurricane Helene. We hope for a comprehensive response and recovery process as these areas continue to respond and rebuild, hopefully stronger. So there is still a ways to go in a very challenging environment to provide a more certain path forward to encourage needed investments and to achieve more convenient, person-centered, affordable, longitudinal care. Today, we're here to discuss the short and long-term steps that can provide opportunities to overcome these challenges and accelerate progress. For example, specialty care payment reform. Despite accounting for the vast majority of healthcare spending, most specialist physicians are not actively engaged today in value-based arrangements. Duke Margolis, in collaboration with specialty care providers, experts, and other stakeholders, has developed a framework for engaging specialty care providers in accountable care reform. These providers have often felt left out, especially those that could play a greater role in longitudinal collaborative care models with advanced primary care practices. Reflecting some similar ideas, CMS is currently implementing a specialty care reform strategy that includes a mandatory model for acute specialty care, the Transforming Episode Accountability Model team proposal, and that seeks to encourage specialty coordination and advanced primary care models through other policy steps. Second, CMS and many healthcare organizations are seeking better ways to help healthcare providers, especially smaller practices, succeed in accountable care. With this core accountable care chassis increasingly well established, the challenge is increasingly how to improve existing models and spread best practices faster, taking advantage of better and more interoperable data and analytics systems, including health AI. Third, with accountable care more prevalent and mainly being delivered outside of CMMI, Innovation Center models, including in the Center for Medicare programs like the Shared Savings Program and through Medicaid reforms overseen by the CMCS, the Center for Medicaid and CHIP programs, there is now an increasing need for increased cross CMS coordination, CMCS, as well as CMMI, to help advance multi-payer models that reduce burden. Just as Medicare has helped drive administrative standards in fee-for-service that have been widely adopted across payers to support fee-for-service care in a wide range of contexts, accountable care needs an administrative pathway towards being a less burdensome new normal, with standard measures and supports and administrative efficiencies, rather than a range of alternatives across different payers that can create significant additional burdens for providers who want to make this shift. And in the near term, Congress is considering MACRA reforms. While MACRA, implemented over the past decade, was intended to help physicians move into value-based care while stabilizing their payment system, it has faced some significant complications, and there are a range of calls out there today for reforming and updating it. Finally, almost goes without saying, this is occurring in the midst of a very dynamic healthcare environment with rapid changes in progress from biomedical innovations like GLP-1 drugs to cell therapies, early and growing impacts of health AI, as well as horizontal and vertical consolidation and concerns about pricing in healthcare. So a lot on the table today. Before we begin, I want to give a special thanks to West Health for the long continued partnership with Duke Margolis to accelerate the adoption of effective accountable care across the nation as part of their mission to improve affordability and outcomes for older Americans, particularly those with limited means. And I want to give a special thanks to Shelley Lyford, the CEO, chair, and as well as trustees, and trustee of the Gary and Mary West Foundation, and chair of the West Health Institute, who unfortunately couldn't be with us today. So with that, I'd like to kick off this event with an important session on where we are and where we're headed on Medicare reform and innovation, with the goal of helping to assure that Medicare beneficiaries' needs are met as efficiently as possible. Healthcare payment policy related to value-based care has been an important part of that goal, but the person who's joining us for this keynote kickoff session has been involved in a huge range of healthcare reforms, and I've had the privilege of working with him for now a couple of decades, I think. Dr. Michael Burgess is a leading member of the U.S. House of Representatives, played a leading role in the Energy and Commerce Committee, and has been deeply involved in a wide range of healthcare reforms. He's also a physician with nearly 3 decades of experience practicing medicine, on top of a couple of decades on practicing federal health legislation, including the Medicare Modernization Act, MACRA, and other critical health stimulus legislation. So, Dr. Burgess, thanks so much for being here today. You're going to come up and join me on stage. So there's obviously a lot we could talk about. I know we are speaking briefly before we got started and touched on some of the same topics that I brought up in my introduction. You've been working to improve Medicare and help make sure its benefits keep up, including drug coverage and other innovative benefits. And especially, Dr. Burgess, with a focus on helping clinicians lead in delivering care despite all of the concerns about costs and access and complications in care delivery. So you've been at this for 20 years. You're about to retire from Congress and move on to the next phase. What are your reflections about where we are and where we're headed?
If we'd done a better job, we
wouldn't be here right
we
now.
wouldn't have to have this conversation. The biggest threat right now that I see is the continual erosion of the physician fee schedule. It's been going on for years. It's been accelerated in the past couple of years, adding to that the significant inflation rate. And when I talk to colleagues, all I hear is I can't afford to keep my practice open. So I will tell you, even in my house, my wife wanted to change, we're both on Medicare Advantage, and she wanted to go to a doctor who was closer to home. She made an appointment with a new doctor, and then she got there and they said, "Oh, honey, we can't see you because we don't take Medicare." And that is a problem for patients all over the country. And that's our problem as policymakers, because even though I tried to fix things by repealing the SGR when MACRA passed, still the inevitable pressure of trying to balance budgets and try to reduce federal spending has come down, and the focus has been on physicians. And really, in my opinion, that's really the wrong place. We need to empower our doctors to be able to make decisions and make timely decisions and take care of their patients. When I first got here, everyone loved to talk about the patient-centered medical home. And I read about it. I thought, that's what I used to be before they drove me out of practice with all their crazy regulations. So I do think I know before the end of the year, what's going to happen before in the lame duck before the end of the year. We have to do something about the physician's fee schedule. It will not be enough. I've been through this fight so many times, right? 2020, COVID, and we were all at the end of the day singing songs to our doctors and ICU nurses and banging pots as the sun went down. And then we get to the end of the year and they said, "Thank you very much, doctors and nurses. Oh, here's your pay cut." And they went, "Wait, what? A pay cut after what we did for you?" And unfortunately, it's just continued year in and year out. I do think we will have to do something on the physician's fee schedule. It will be temporary. It will be nowhere near enough. The erosion of the physician's workforce will continue because, at least in Medicare, will continue because of that. But at the same time, I'm hopeful, ever hopeful, that there will be renewed attention placed on this. One positive note, in the Energy and Commerce Committee, for the first time, we actually had a hearing on budget neutrality, and we did almost a markup on.
This is related to some of your work on coverage of preventive-oriented treatments or drugs or other therapies that may have costs in the short term but benefits over time.
Well, a physician's fee schedule is set to be budget neutral, and it doesn't always work that way. So the updates on budget neutrality and how the physician fee schedule is derived at, it's the first time that I can recall in my 20 years of Congress that we actually did anything at all at the committee level. Still got some work to do, and God knows what's going to happen in the Senate, but that is the type of attention it will take. And my hope is that at the next Congress, whoever's around, starting early enough, they will be able to get something done in this space.
I do think, kind of looking back on our work together, you're right, we haven't solved the problems yet, but I do want to continue to get your insights about what we've learned along the way. So with Medicare Advantage and the Medicare Modernization Act, the coverage of prescription drugs, that was all intended to set up programs that, got as you're saying, a relatively small part of Medicare spending goes to physician services. Most of its institutions or the procedures, the drugs, and other things that they can influence. And a lot of these reforms, including the primary care medical home, advanced primary care, that has seen some uptake in the shared savings program for primary care, has led to some increases in funding available for practices in Medicare Advantage or maybe in advanced alternative payment models, ACO REACH, that the physicians in those practices, I think, are having have had a somewhat better experience financially and otherwise, but that hasn't really reached most of the other specialists, and I know you're one of those. But it does seem like we haven't, despite all the effort that you put into MMA macro, we still haven't really shifted that balance enough.
Well, I wasn't going to talk about this, but you've provoked me now.
I'm trying to.
Look, of course, a big problem in healthcare, as we know, is consolidation. It's gotten a whole lot worse since the ACA passed, but it's always been an issue. And now it's kind of on steroids. I do think that if we allowed, again, for physician ownership of hospitals, particularly in rural settings and underserved areas, allow the doctors to be investors in the very institutions in which they're going to work. Now, I know Pete Stark fought against that for years, and when they passed the Affordable Care Act, they said no more physician-owned facilities because they're just going to self-refer and it's going to be a bad deal. No, why should a hospital be able to own a doctor, but a doctor can't own a hospital? I mean, it's almost anti-American. My belief is that if we will relax that policy and allow, in certain situations, for physician ownership in medically underserved areas, that it will be the reverse of consolidation, and that would be a healthy move for the market.
Most of those specialty hospitals, that you're right, there's been a moratorium. There's some pre-existing ones, but moratorium since the ACA. Most of those involve different kinds of specialty care, cardiovascular care, orthopedic, et cetera. Is there Are these specialty areas? Are there other things we can do to help the specialists in addition to, in your view, the eliminating this moratorium?
Well, I think the the potential is vast, and you think about just a general hospital or a hospital that primarily does obstetrics. I mean, there are areas in the country where it just isn't available, and yet, the doctors who live there would like to be able to provide that service. So let them participate and let them be owners of their own facilities. It doesn't have to be owned by I mean, even nonprofits sometimes don't feel like nonprofits. Forgive me for saying that in this audience, but allow the
Say that in any audience.
allow the physicians
A
to
lot of
do.
the audience might agree in some ways.
Well, I do remember having a discussion with Dr. Berwick, who was your successor at CMS, as I believe, and I talked to him as the ACA was going through, and I said, if you would, he complained, not complained, but observed that his dual eligible patients, which were readily identifiable, small percentage of the overall population, but spent a large share of the dollars. And I said, if you would just give each of those patients a doctor to make them accountable to the patient, that you actually could take better care of patients and it wouldn't cost you as much money. And he sort of pushed against the idea and said, no, there's other things we can do. But I notice now in my we're in that open enrollment period time in Medicare, so a lot of advertisements on television where people are if you're dual eligible, if you're eligible for both Medicaid and Medicare, we've got a fantastic plan for you. And it may include meals and rides to the doctor, things that might help keep someone healthy and out of the sort of the end stage of the healthcare delivery system. So in an odd way, now 20 years later, it's sort of the commercial payers are becoming aware that there's a ton of money there in taking care of the dual eligible. Do it correctly, provide good care, and if we set the standard, maybe we can be the leader in that.
Yeah, and commercial and some of the areas where accountable care is growing are actually in Medicaid plans, including increasingly in dual eligible plans. Just keeping with specialists, I don't want to put words in your mouth, but I assume your views on specialty hospital ownership extend to your views about payments for care that's delivered in an ambulatory versus a hospital setting. There have been proposals for making those payments more reflective of the savings that can happen when care is moved out of the hospital and into the community, kind of picking up on your point. Is there more that we could be doing there?
Yeah, I think we've had this discussion before when you put a moratorium on that. But I think surely some smart person can do the studies and demonstrate that. When I was an owner in an ambulatory surgery center, if I had a patient who was covered by Medicaid, for example, what's the most important thing to me? It's my time. If the turnover time in an ambulatory care center is really quick and I can be done with those cases in a few hours as opposed to all day long and then getting bumped at the end of the day for the emergency appendectomy that came into the emergency room, yeah, I'll take the quicker, take
Mhm.
the quicker turnaround time. It's not because it's being done in my facility and I'm going to make more money off it. It's just there's less of I'm tying up less of my time. I'll be available to do other things. I actually wrote that for health affairs years and years ago.
Mhm.
Nobody paid any attention to it, but I think that
I think they
concept is
do.
still true today.
Well, and I know you weren't a supporter of the ACA, but you have been a supporter of the Physician Payment Technical Advisory Committee, which is we were talking about again
And that's not
just before we
ACA.
started.
That was
Right.
MACRA.
That was MACRA.
That was my
That
bill,
was
not your
MACRA. That's
bill.
right. That's your bill. So the ACA is not. I'm not saying that's my bill either. That was. Let's get back to the question. The MACRA proposal related physician payment technical advisory committee, I recall discussing with you at the time, was intended, I think, in part to try to help get more payment reform models and more supports implemented for some of these areas, especially care that you've just been talking about.
Yeah, and you wanted
What's happened?
you I think back to the days even when I was a kid. My dad was a doctor, and the county medical society would do a good job of policing themselves. Well, those days are kind of long gone, but doctors do know how to define quality and what represents quality in a care environment. So why not keep doctors in the mix? And that's what the PTAC was designed to do.
Mhm.
CMMI all well and good, and ACOs all well and good, but if you're going to have a value-based model, wouldn't it also be wise to be sure that what is being delivered there, the care is quality care, and that it actually makes a difference for the patient? And that was the idea behind keeping docs involved on the technical side.
Mhm.
Unfortunately, Obama administration, Trump administration, Biden administration, they have not been their respective secretaries of HHS have not been as receptive as I have been to that concept. So it's been a little bit difficult. But I actually am working on a new bill now to try to re-energize the PTAC part. I mean,
Mhm.
that's current law. It was signed into law by President Obama, and we should be doing that. But no secretary has actually, I mean, yes, the boards have been created. Yes, they have met. Yes, they have provided some direction. But then when it gets to the inner sanctum there at HHS, it gets ignored. So I'd like for that to actually mean something. And these docs participate, and the doctors, the groups that put together proposals, and here's a way we can deliver, say, urology services for a great number of people at a lower cost, at high quality. They want to participate. They
Yeah.
want to be a part of that.
Yeah. And before we look forward, again, that's where we go from here, where we started out. One other key component of macro was some steps intended through the Medicare Incentive Payment System, MIPS, to help specialists and others move in that direction with performance measures that ideally would be practice relevant and so forth. And gosh, you had a hearing on this recently, and a lot of concerns out there about how MIPS has worked out.
Yeah, I've taken a lot of criticism over MIPS even before the law was passed.
Mhm.
I forget someone, I think one of Chairman Waxman's staff said, why don't you just call this the everybody gets an A provision? Because they said it's going to be too easy to meet the criteria. But you want your doctors to succeed. This should be the whole point of this. The reason when we were having the original discussions about what to do next, if we're going to
Mhm.
move beyond the SGR, then Majority Leader Eric Cantor looked at me and he said, Doc, wouldn't it be easier if we just put all the doctors into an ACO? And the answer is yes, that would be easier, but I'm not sure that's the right thing to do
Mhm.
because you've got a lot of areas, rural areas, where that just wouldn't work.
Mhm.
And hence was the development of MIPS. Now,
Mhm.
again, not only Henry Waxman's staff, but also doctors themselves. Hey, wait a minute, I don't want to have to fill out another set of check boxes on top of the meaningful use stuff that you put on me with the electronic health records. I don't need more paperwork. I need more time in the day to see patients. So it has become, in their minds, overburdensome, and the reward for doing it is insufficient to make people feel that it's been worthwhile. I asked in a hearing if someone thought that, hey, let's just do away with MIPS and put everyone, even small practices, into an APM. And they said, that'll never work. And so I don't know if someone's smart enough to, if over the years we have now figured that out, but clearly, well, Morgan Griffith, who was the subcommittee chairman, he's got a very rural district in Virginia, and patients have to drive a long ways to get to a doctor. He's not interested in removing any doctors from his system. He wants to empower those that he has and encourage more to move to the area. So the MIPS program is, he was interested in I think he was interested in some reform there, but again, it's got its enemies on both sides.
Yeah.
When we started the hearing, I said, well, I came to bury MIPS, not to praise it. But I think you need it, even at the time that MACRA passed in 2014, 2015, you needed something like that in order to keep the 1 and 2 doctor practices involved. Have we reached a point where now maybe a shared savings model of some other stripe might do the trick? It might, and I'd certainly be willing to look or listen. You've asked me what I was going to do next. I will only tell you I'm not going to do anything that requires Senate confirmation, but I will keep the same phone number so you can call me for advice.
I'll definitely continue to do that. And then just one more element of MIPS was this payment bonus for physicians who did get into so-called advanced alternative payment models. Now, that's been important for, I think, mainly the ACO practices, mainly driven by a lot of the primary care docs. So I guess there's a lot of specialists that are part of some ACOs. Is that still, it's something that they all view as quite an important incentive to help continue to make progress?
I think the answer to that is yes, but there's just been people are so discouraged over what's happened with the physician's fee schedule. Remember, MACRA, as originally written, was over 10 years' time, was to provide a 1% update to docs in practice, 1% a year for 10 years. That did not survive the multiple committee processes that it has to survive, and it got cut
the
down.
Budget review and
got cut down to 0.5% for 5 years. And then here's the difficult part of the story is now we're out beyond that 10-year window even, and there's been no update. And docs look at it and they say, I'm behind before I start, and then there's cuts to the physician fee schedule going forward. I don't know how I can keep my practice open.
Yeah,
and that's what's going to hurt.
And then on top of that, it's even harder to say, well, how do I succeed in an alternative payment model and redesign and make all the necessary supporting investments? But it does seem like, Dr. Burgess, that at the core of this, you still believe that Medicare and that our policies should do more to support and pay for clinical care that's good, that reflects best clinical practices. Maybe we're not there yet on the measures. Maybe we can get there. You still believe that there are better ways than fee for service to get to coordinated care and the like, maybe for specialists. You're still, I think, a believer in getting to more sustainable finance. You're definitely a believer in more sustainable financing for physician practices. Any final thoughts about advice for you're going to have to deal with this? I know there's not much time left before the election, but this is going to come up in the lame duck. We were talking before. You think something's going to happen in the lame duck session, and
I do think there will be an adjustment of the physician's fee schedule. Going back into the mists of time, when Secretary Leavitt was at HHS, there was something called the Physicians Practice Demonstration Project, which I believe was the forerunner of ACOs. Now, my thesis is that Dr. Berwick messed up the ACO concept, so it's been difficult to recognize. But that really was a shared savings type of concept. And I do think long term that is the type of model that needs to be considered. Look, doctors are intelligent, they're driven, their motivation is generally correct. And if you can point out how you can do something better than the traditional way of having always done it. One thing I'll always remember when Secretary Leavitt had a roundtable about the physician group practice demonstration project was the revelation that treating someone who had come into the hospital for bad congestive heart failure, they'd decompensated, and it was quite a rescue operation to get them up and going again. The typical standard thing was say, now you're ready for discharge, come back and see us in 2 weeks' time. And if you amended that to say, come back and see us in 5 days' time, the likelihood of a rehospitalization just plummeted because you were able to catch someone as their weight was going up. As a way, wait a minute, you didn't adhere to the diet. Coconut cream pie was not on the list, and and you were able to intervene. You were able to do something. Now, I think with newer technology and wearable devices and AI and physician extenders, that's a lot more possible now than it was in 2004, 2005. And I think that's the type of, that's that to me would be quality, and that would be quality that would have a deliverable. There would actually be savings, and yes, share that savings with the physician, because it's a lot of investment to get things set up. You have to hire additional personnel. You may have to change your computer system. All of that's going to require investment. Make it worth people's while. But at the end of the day, you want to do a better job taking care of the patient. And here's this was the dark side of that story. Then the next administration came in and they said, okay, we've seen the wisdom of not having someone have to be rehospitalized because you were so long into getting around to see them. We're going to punish you if someone's rehospitalized within 30 days. And that led to all types of unimaginable bad behavior on keeping people out of the hospital, or finding, this extended time in observation in the emergency room. It led to all of the bad problems that you see downstream from that. But the idea of the concept was a good one. Better care of the patient, have them come back in 5 days, assess how they've done on the regimen you're sending them home with. And if it's not working, you make some adjustments there before you have to bring them back into the ICU.
And really helping physician groups, primary care, especially otherwise, deliver better care, which is what they want to do anyway. Well, we're not there yet, but I really want to thank you for joining us today, and especially Dr. Burgess for 20 years of determined commitment to try and make healthcare better. And I'm sure since our work isn't done, we'll be staying in touch about this.
Yeah, absolutely.
Great to see you.
Thank
Thank you. Thanks for joining us. And after, we're going to try to build on Dr. Burgess's remarks. We're going right into our next panel on building on MIPS and alternative advanced payment models to improve Medicare's payment systems. Come on up. To get started with this panel, I'd like to begin with introductions. That includes Susan. You can sit wherever. There's no seeing chart assignment. Yeah. Susan Dentzer, who's now president and CEO of America's Physician Groups. Michael McWilliams, the Warren Alpert Foundation Professor of Health Policy and Professor of Medicine in the Department of Healthcare Policy, Harvard Medical School, and also Aisha Pittman. Aisha, good to see you again, Senior Vice President of Government Affairs at the National Association of ACOs. Okay, well, you heard a lot from Dr. Burgess, who I've been around Washington for a while. I can't think of anyone who's been more steadily involved, particularly on the Republican side, around trying to make payments work better, as you heard him say, in 20 different ways for physicians and physician groups and advanced practices to deliver better, more convenient, less costly care. But boy, we seem to be having some progress on the one hand, but some real challenges in moving beyond where we are today. So I'm going to start out with I wouldn't call it a softball, but try to give me your best ideas about what should be, in terms of big picture reform, where should we be headed in terms of trying to accomplish these goals of accountable care and implementing more effective. I think we've learned it's not just, as you heard from Dr. Burgess, not just the payment models themselves, but a whole lot of other related policies that interact to influence physician practice. Michael, you're nodding, so I'm going to start with you.
Sure, why not? So I'm going to try to duck this question by saying I think that the big picture challenge is actually really small picture. because it's now been 12 years. We, certainly put in a lot of effort. There's been a lot of progress.
But 12 years, but I mean, go back to
12
the
plus,
physician group practice
totally 20,
demonstration, all that.
25
You
with
got 20,
HMOs, 30,
yeah.
40 years,
Yeah.
but we are still struggling. And if you look at the payment system, and I don't mean just the multi-payer issue, I mean within traditional Medicare, not just the non-APM sector, but the APM sector, the incentives still largely look like fee-for-service. And that is largely a product of a lot of the model design issues that we have yet to work through. And so that's my big picture comment. But beyond that, when you start unpacking that, things get really weedy, just sort of headache-inducing, mind-numbingly complex. But these are issues that we really do need to tackle. And from my vantage point, it seems like these sorts of issues get short shrift in sort of high-level policy conversations when they're actually the crux of
Give me an example of one of those.
Benchmarks. And so we really have to have a long-term vision of what the alternative payment system is going to be. What does a population-based total cost of care payment system with an embedded primary care total cost of care payment system look like? And then how do we chart a course to get there? The issue with benchmarks has been twofold. One, for any given provider, if they lower their spending, that gets sort of like penalized with lower benchmarks in various ways. So then what's the point to ever save? It's very hard to engage specialists if there's no savings to sort of share if you're generating them together. And then the other is sort of more of a collective thing where there's a big emphasis on participation, which I agree with. But if you think about why we've stalled, it's completely predictable. It's just the benchmarks are set in a way that only half of providers can ever find these models really financially viable. Only half can ever sort of get below their benchmarks. So then how do you do that? I should probably not go on at this point about that, but happy to if we start digging into it.
Yeah.
But I think if we do that, then we can start accomplishing the goals, which are participation and savings. I think the advantage or goal that often gets underappreciated is the flexibility. And that's where I see a lot of the quality improvement coming from a population-based payment system, is the ability of providers to sort of innovate and deviate from the fee schedule in ways that benefit patients. And then from a policy perspective, that gives us a really important tool for dealing with a lot of care that is just hard to price and hard to stuff in the fee schedule. It provides a way of paying for that and accommodating that, helps us navigate that trade-off between care delivery innovation and cost containment, because if we keep just putting codes in the fee schedule and attaching high price, we're going to keep increasing spending. So we need to do it in sort of more of a fiscally responsible way.
I do want to come back to that, and I might make it even harder by saying, like, okay, what should we be doing in the near term, like in the context of macro reform and some of the issues that Dr. Burgess was so focused on. But first, Aisha.
In terms of goals, I'm going to agree in terms of what's our overarching goal with cost, and the benchmarks are a problem, and we have to really think about what's our end goal. Is it reducing costs, or is it just shifting what we pay for? And I think if we look at certain things like the primary care capitation models, they're never going to achieve savings because we're just shifting where the funds are going. And I think many primary care doctors want that, but it's not meeting the overall cost saving goals. And we're at this critical point now. We have several members who are leaving the shared savings program because they're about to hit their third contract. Their benchmark is ratcheted.
And that's the point that Michael was talking about.
Yep,
so the
exactly.
benchmark goes down based on a significant part of the reductions in costs relative to the underlying, I guess, fee for service, et cetera, trend.
You've been successful, you're ultimately penalized, and that takes away your investment. But I think the other goals that we still really need to emphasize and probably have not spent enough time looking into is the goals to patients. The quality measures are there, but if we think about things like primary care docs have 24/7 access, care managers, that is standard now for providers in accountable care models. That was not standard before all of this work started, and that just drives benefits to patients. Shared savings payment goes directly to other patient services, and we don't talk about that much. We talk about the shared savings, and there's $22 billion in MSSP over the course of its lifetime. But what is that? Where do those shared savings go to? It's more provider payments and more services to patients. So I think those are two good things that we need to quantify better and look at our overall goal of, are we getting better services to patients, and are we reducing burden for providers?
All right, remind me, we're going to have to come back to savings at some point during the session too, but Susan.
So I agree with everything my colleagues have said, and I think what underlies their comments is that there were lots of things that we did at the outset of the movement to value that were sort of in the category of it seemed like a good idea at the time, but it turns out in retrospect, they weren't really very good ideas and they were inherently flawed, right? And so what we have to do now is step back and examine all of those. So let's take some examples. So MIPS, and this is a point Mike has made in his work, MIPS was based on this assumption that the way we would get to higher quality is one doc at a time, right? One doc at a time, being coached into doing a little bit more quality at a time. We know now that's not how you achieve quality across the healthcare system. It's not one doc at a time. It's more systems orientation. Okay, so that was a flawed assumption that we now need to bury. We're with MedPAC at APG on that. MIPS should be dead and buried. Okay, another flawed goal. The parameters that were set around shared savings models, et cetera, was they either had to improve quality without increasing costs or save money without decreasing quality.
Yeah.
Okay, perfectly valid assumptions, except for that doesn't say, are we investing appropriately as it stands now in certain areas of healthcare? And the answer is no. We were way underinvested in primary care. So holding primary care models to that kind of a metric was crazy. It was crazy 20 years ago. It's even crazier today, given what we face in terms of primary care shortages, et cetera. Third flaw, we should do this voluntarily because God forbid we're in America. We should not make anybody do anything they don't want to do. All right. So who was going to go into these models where, number one, they needed all kinds of capabilities many of them didn't have in the first place. Number two, they could be subject to the ratchet effect, right, and actually lose money when fee-for-service was there lying like an oasis that they could flee back to, right? And so, like, who thought that was a good idea, right? So now, as we put all those learnings together, to me, the challenge is, how do we learn from all of that, say goodbye to all of that, literally, and try to figure out, again, what Aisha said. So what are our goals? What do we really want to accomplish? And what is our current context? And the current context, as you and others said, was physician shortages, high costs, practices closing. By the way, the leading edge of the baby boom will be 80 within a year. Chronic disease rates are skyrocketing. So given that that is the context, how do we do this now in this new, very different environment from what we were looking at 20 plus years ago?
So those seem like kind of big fundamental reforms, but are they really? And how do we get there? I mean, it does seem like we have, 50 plus models, most of which were voluntary and couldn't, check all of these boxes at the same time. And yet, as I mentioned at the outset, we've got a large share of people in traditional Medicare and a larger share of beneficiaries in Medicare Advantage that are in some form of a fee-for-service base per person payment.
Some are in a non-fee-for-service base.
Some.
Yes.
Is that the core model still? And can we sort of declare victory on that and then start working, as Michael was saying, on some of the details, like getting the benchmarks right and moving maybe to, I heard benchmarks, I heard mandatory models, I heard maybe better, more meaningful performance measures as part of
Well,
it?
as you said earlier in your opening comments, so we've got about 13 million traditional Medicare beneficiaries that are arguably in MSSP and related models. So to meet the CMS goal, which by the way is only traditional Medicare, they don't include Medicare Advantage in that goal.
They've got a MA piece too.
But it depends on who you ask over there, right? Okay, so we would have to move 4 or 5 million patients a year into ACOs.
We are not on that pace.
We're not on that pace.
But you're not answering my question.
Right. Well, so, and we're not on that pace in part for all the things that everybody here has talked about, right? So what would we need to do, right, to move to that pace? I think that's where we have to go back and fundamentally reinvent this whole system of benchmarking. And frankly, it is going to take more investment. And that's the dirty little secret nobody wants to talk about, because it's still, the conversation is all about saving money and getting money back into the hospital insurance trust fund. And it can't be that, given where we are in the country today.
Can we talk a little bit about benchmarks now? Because it sounds like that came up again. So we've talked some about traditional Medicare benchmarks and the ratchet effect. But as Michael, I think, pointed out, those benchmarks not only have a ratchet built in, they're kind of built on kind of fee-for-service and traditional approaches. If you look at Medicare Advantage, those benchmarks are definitely built off of fee-for-service and traditional kind of practices and not, you know, sort of a lot of risk adjustment for some of the prevention-oriented care, some of the kinds of things that matter in these alternative care delivery models. So what do we do about the sort of benchmark pieces? You know, the nice thing about things that seem like details is maybe there's a pathway that doesn't require fundamental major legislation to start making progress if we're clear enough about where we need to go.
Yeah, I completely agree. And so I agree with you, Susan, that this is going to take work, but I love the optimism, Mark, and I think that's exactly right, is that we can build on sort of what exists. What I would probably prescribe, for lack of, I am a doctor, so I guess I can say that word, but
Yeah.
would be a combination of some things that look like the APM bonus. So it's just sort of some add-on payments in the expectation that incentives to save will be stronger, we'll see more savings, so that that won't be inflationary. That has to be sort of a permanent add-on, though, because what we really need is, for as claims expenditures sort of slow as ACOs save, the benchmarks need to, they can't chase them, right? They need to rise above, particularly in a voluntary program. Otherwise, no one else is going to join who's north of that sort of average spending level. And so that's one way to do it, but it does require sort of a more permanent mechanism for establishing that sort of cushion or wedge. And I'll come back to that. The other way to do is just to preset a rate of spending growth that's desirable or forecasted in some way, and not have it chase spending as
Sounds like
it
macro.
falls. The shared savings program actually already did this. It's called the Accountable Care Prospective Trend. And so we can have endless debate about what sort of rate might be desirable. You might want to set ex ante. But the key is it just remains fixed over a substantial period, so that it doesn't sort of follow success downwards. And what I like about that is that it allows that cushion or wedge to grow as savings grows. And so maybe a combination of those two things is sort of the mix of what we want to get to a point where first of all, it gives all providers a chance to prosper in the program. They can all get under their benchmark. Medicare saves in the meantime, and then you have a more sustainable program and can go from there. And I think then we have to think about what the next phase of benchmarks looks like after that. For that add-on payment, the APM bonus has sort of been a temporary thing. It's sort of like to sort of make things less turbulent as providers enter the model, but then after they get in and safely get under their benchmark, in theory, can be lifted. But this would require more of a permanent thing. The APM bonus is also not structured the way we probably want it to be, because it's a fee bump. It's a percent of revenue. So that sort of undermines the purpose of sort of lowering overutilization. But also, because it's percent of revenue, and revenue is higher for specialists in primary care, it sort of goes against sort of the efforts to sort of shift payment towards primary care. And it also goes to the health systems with more specialists. So there are issues with the way it's structured. If you start restructuring it as a per beneficiary payment, which would be my ideal, that's primary care capitation. So then we're sort of in a world where maybe we should be thinking about this as a combination of benchmark reform and holistic primary care payment reform, where we go further with primary care capitation, the generosity of that payment within the shared savings program. CMMI did implement a model. I should say I'm here as an advisor to CMMI, called Flex, which is a great start in my opinion. And that could be built on to sort of establish that piece of the puzzle.
So Aisha, maybe you could pick up from here, and I would like to go, but I didn't hear a lot that's necessarily going to lead to scoreable budgetary savings coming out of what Michael was describing.
Oh, no, you get more in, more
you get more
savings,
in, and then
Medicare's still
over
getting
time.
a cut. I mean, you probably want higher savings rates, but Medicare sharing in the savings all along. In contrast to today, Medicare can't share in the savings because there's no savings, because there's no incentive to save.
Yeah.
So it's giving providers an incentive to save,
exactly,
so Medicare can win.
But I was emphasizing is that you had talked about the quality side of this too, 24/7 access improvements, et cetera. You talk about how that approach fits in as well.
Yeah, so if you fix the benchmarks and providers can have higher shared savings, that is what they reinvest in, all of these services that go back to patients. I think one of the challenges that we have now is it's a black box of where these shared savings go. We know anecdotally from our members, but I think that can prove that we are actually lowering costs beyond just our quality metrics. I think also piggybacking off of Michael's approach is a lot of the challenges we have now is which providers are eligible to get the advanced APM bonus, and specialists are not eligible if they don't have applicable models. So there's been a lot of work of thinking about niche models to fit specialists, and that's really counter to the overall population health goals. If we have that type of approach and it's based around primary care and the accountable care entities have better shared savings, they then have the ability to negotiate with specialists and focus on narrower networks and referral patterns. And many of our members are doing negotiated discounts with specialists now in their Medicare Advantage contracts. You would give them the funding to do that type of activity within the traditional Medicare APM programs as well.
And Susan?
Let's keep Medicare Advantage definitely in this conversation.
Well, I was going to
because
ask you more directly about that. I know a lot of your members are.
Yeah, and at the latest numbers show 55% of beneficiaries now are in MA plans. And we are the first to say MA is not a monolith. Not all MA plans are created equally. Most MA payment still flows through fee-for-service, not risk-based delegated models. Many of our members at APG are in those delegated models. Plans get the capitated payment from the government. They turn around and pass most of that on to our groups, and our groups have that
flexibility, like Michael was talking
bolus
about.
of funds to do the right thing with. And we totally agree with Mike Burgess that docs are going to do the right thing when they have the right set of incentives, which we think those arrangements do. So if that program is growing fastest, and obviously it's because a lot of people like the supplemental benefits that are in that program, dental, vision, and hearing. They like the fact that they don't have to spend a small fortune on Medigap plans, which is the only way. I mean, 90% of traditional Medicare beneficiaries have to buy Medigap to make that benefit structure work for them because there's so many holes in that benefit structure. So there are lots of people who are voting with their feet to
The ones who couldn't afford it.
to leave that behind. And yes, and by the way, it's a much more socioeconomically diverse set of beneficiaries who've opted into MA plans than is true now, even in the traditional Medicare
But to
program.
Aisha's point, do we need more transparency about some of this? Like, what is going on with the alternative payment models within Medicare Advantage? You're right that some of them are, it's now a majority of the program, and yet we're basing these AAPM bonuses off a decreasing minority
but if you're in a,
of the
if you're in a
population.
delegated relationship, that is your alternative payment model right there. You don't
Is
have
that
to worry
something
about
we should
whether you're.
be measuring and
Yeah.
incorporating into policy going forward?
Thank you for
MA
teeing up the
becomes-
question, Mark.
Okay.
Yeah, we have said to CMS periodically, why don't you incorporate this into star ratings? We have research that Ken Cohen here and others on our collective team are leading that we think can show that when you are in a two-sided risk model as a physician group, so that is to say you're in Medicare Advantage, you've got the money is handed to you and you can win or lose based on how well you take care of patients. You get better results. And we think we know, we're confident we can prove that. So if that model works, and most of the populations of elderly and disabled people seems to want to go that direction, why don't we build on that as a very powerful classic example of value-based care? And I would say one other thing, which is if we're going to save money in this environment with an aging population that is increasingly ill, and physicians faced with all of these other costs and healthcare systems faced with these costs, we have one big potential source of savings, and that's driving out all waste and low value care, of which we believe is still a lot. You know, depending on who you believe, it's 30%, it's $1 trillion, whatever. So if we could drive that out of the system through getting everybody in any which way or form into a much more accountable models. And again, back to what Dr. Burgess said, docs know how to do that. And some of the care that can be driven out that is unnecessary care is frankly still unnecessary hospitalization that costs the most, right? And so if we could gear all of that up, go after that low value care, create these models that people seem to like, I think we'll get somewhere.
And putting these ideas together, I mean, it does seem like there is a path forward that could get to savings and improvements in care. But it sounds, as you were saying, a different way of what saying, Michael, is, the details matter here. That's a pretty difficult technical challenge. Maybe another way to get more savings faster and get more attention to fixing problems with benchmarks and things like that is to move to more mandatory programs, as Susan mentioned earlier. Do those have a place going forward as we're seeing more organizations moving into accountable arrangements in both MA and traditional Medicare?
I think if you structure them right, then the need for mandatory reduces. I think why folks, it's a losing proposition to go into the models now because of things like how the benchmark is structured and the ratchet, and that you are penalized for your success over time. Why, when fee for service is so good, but if we can do some of the things to increase shared savings, address the benchmark approaches, you would naturally have the incentives are there.
Is a both and possibility here?
Possibly.
Yeah, we can certainly step up the pressure, I think. I'm not sure about what's mandatory, right? It's sort of some set of penalties or, some set of disincentives. And so
Some movement away from a base fee for
carrots and
service
sticks.
line.
And so certainly the incentives to participate are not strong enough. I tend to think that strengthening the incentives to save should pull in plenty more providers. We're sort of halfway there in traditional Medicare. There'd be another swath that would come in just because it provides a better opportunity than fee for service. There would probably need to be some additional measures taken. But that initial, I think you're referring to sort of some of the budgetary impact of sort of voluntary versus mandatory. That's sort of more in the short term, right? Because if you get everyone in, they're under their benchmarks, like then you don't even need to have downside risk because the downside of higher spending is lesser savings, not like greater loss.
You should go to Dr. Burgess's next hearing where they talk about 20-year savings estimates rather than the
and of
ones.
course, and we should be focused on the short term too. But the problem is that we've been so focused on the short term, and incentives are a long term. You have to think about what's going to
invest
over the long term in order for there to be an incentive for short term action. And I guess I'll also just say though that savings are great. They make the program more fiscally solvent. But what we really want to do with the savings is do something valuable for enrollees in whether that's the current enrollees or future enrollees, future beneficiaries. And it seems like we're spending enough in the Medicare program, particularly with higher Medicare Advantage rates, to accomplish that. And so there is underuse and unnecessary care, but there's also this issue of limited competition in Medicare Advantage and insurers being able to sort of siphon off a chunk of the surplus there. And so that raises questions about how can we strengthen competition so more of that flows down to the enrollees. And then larger questions about how do you, do we rebalance the program? Do we do an MA for all program? Why are we talking about APMs if MA is going to be 80% of Medicare in 10 years? So there are some broader questions here about sort of how to get more value out of the program.
And I'm really glad you teed those up. We've got a couple more panels, and I know you all are working hard on those long-term issues too. One question I want to close with the question of what can be done, what's feasible in the short term, administrative or legislative. So think macro, or think something that could be in a CMS proposed payment reform or CMS payment rule or MA rate notice for 2025. Before we get there, small practices and safety net practices and others always come up in this context. I get the point. I'll pick on Michael. Just why not?
Why not?
That giving organizations flexibility to set up new kinds of payment contracts for new services or negotiate shared arrangements with specialists and the like. That kind of flexibility really is what could drive better payment models. But how is a small group supposed to do that? I mean, isn't that going to be a contributor to one of the biggest political concerns right now, which is too much consolidation in healthcare? And it's not, that was not directed to you to answer. Just
no, I love this question because there are trade-offs involved, obviously. I think we do know from the literature that you don't need to be a huge health system to provide high quality of care. But some modest scale is useful to have the practice capabilities. So I'm not averse to some consolidation from the very low end to some medium size where we're not running into harmful losses of competition. And there are various things that the shared savings program has done to sort of try to help smaller organizations overcome the fixed costs. There are conveners. As long as that market stays competitive and the smaller practices and organizations can sort of shop around, then I'm
So
not as
coordination
concerned about
without
that.
full consolidation.
Yeah. And we know too that those are the providers that actually don't need super high risk powered risk contracts to have strong incentives to save, because they sort of, the waste is not their own. So they're not sort of cannibalizing their own fee for service profits when they're trying to coordinate more efficient care.
The alternative, though, is what in the absence of alternative care, the small practices in rural are having access challenges and already have financial challenges. So in the
it's not any
absence,
better
it's
in fee for
yes.
service.
So I think it's it's a problem, but it's going to be a problem in either approach. And so I think, to Michael's point, we can think about how we structure things that would still maintain independence for small practices, and then also
maybe some financial support.
and also give
with that
support
would
to
be that
rural
expensive.
rural and underserved communities where we know that their benchmarks fail them because it's historically
Okay.
underpaid.
Keeping all this in mind, 1 minute each. What should Congress do around the MACRA reform? You heard from Dr. Burgess, Congress needs to do something. What should CMS do? Top of your list that gets towards the goals that you've outlined here.
Well, to keep it at a minute, I'll just take a piece of that, which is with respect to alternative payment models, particularly now as we face an election, possible change of administration, big changes in Congress, what should be done. Keep some semblance of continuity in a number of these programs without letting ideology bollocks you up. And two quick examples there, the ACO REACH program, which is going to sunset in 2026. Why is it going to sunset? Partly out of ideology and not keeping that program, which has been in certain segments of it extremely successful. So there's not an open mind right now to keeping that program go forward, and there should be. And if the White House changes hands, who knows, it might even continue to exist. But that sort of direct contracting approach, we have to keep that alive.
You said a second one.
The other example is TEAM, because we know that
that's the mandatory
model,
episode,
right?
Specialty care,
and
hospital care
especially
program.
given some of the changes in the marketplace, when you've got most specialists owned by, in effect, by hospital systems, right? And dependent on those revenues, you've got to make this a mandatory model. They won't come into this otherwise, right? So throwing out a mandatory model because you're ideologically opposed to making anybody do anything is wrong in this environment. We can't make all of these models mandatory, but we can make some. And we have the example of the comprehensive joint replacement as a proven example that can produce a lot of change and savings.
Thanks, Aisha.
My two would be first to just continue the existing incentives. They are not ideal. We know that we need to change them in the long term, but that work.
Meaning like AAPM bonus.
The AAPM bonus, primarily, because the alternative is right now physicians can potentially make more money by participating in MIPS. No one likes MIPS. I think there's large agreement that we have to completely reform that. That is all going to take time. So to Susan's point of keeping things going, keeping the APM incentives ensures that clinicians in APMs are receiving higher payments compared to the financial opportunities in MIPS. The second one would be to relook at CMMI's statute and the criteria for which models can be expanded. And I think this correlates to Susan's point about ACO REACH and continuing that. We've tested so many models and very few have expanded because nothing is proven to save money. And so I think it's time that we rethink, is the goal always savings, or is the goal better access, increased benefits to providers, increased benefits to patients, less provider burden, all while maintaining costs.
We're gonna have some discussion about evaluation coming up soon. Michael?
So I'm gonna set MA aside for this because I do think that that's worthy of fairly urgent attention in terms of structural Medicare reform. In terms of APMs on the regulatory side, I think the main thing for CMS to do is continue the direction that it initiated this year in the shared savings program in terms of the direction for benchmarks. And that's probably going to require the Innovation Center to experiment with dialing up and down various parameters so we learn sort of what.
To get to your point of, it's not a knife edge, but there is, it's hard to get that.
It's dialing things,
that dial right.
Exactly. And so in my opinion, it went in the right direction this year. And so to continue that, what cannot be done on the regulatory side is holistic primary care payment reform, because it just turns out that increasing primary care spending does not lower spending on net. It's a great deal. It is, there's no question it's a great deal, and we want to build in more flexibility in the way we pay for primary care. So I would love to see Congress move on that. And there's been a lot of discussions about hybrid payments in general, but I think also considering the interaction with ACO
So
contracts.
when you say move on that, getting more towards a partial person-based
population-based primary
and
care
maybe
payment
lower fee-for-service payments or narrower, something like that.
And we should feel more comfortable going further with the capitated share and the level of generosity in an ACO program, because we are then less worried about cost shifting. It should bring more people into the program, and it contributes to that sort of cushion or wedge. So it's like contributing to sound.
Some of the specialty groups that like in cardiology, orthopedics that have been most involved in kind of longitudinal chronic care would also like, I think, something like that gives them more of a base to work with the advanced.
So that gets to some issues around attribution, which we could probably already over time. But.
That's right. So I want to thank you all very much for a great kickoff discussion, and we're going to build on that in the next panels. Thank you for joining us today. And I think now transitioning to the next panel.
Folks, my panel to join me up on the stage here. So for the last hour, we've been talking about broader Medicare physician payment reforms. We've been looking at macro. We've been talking about broader changes we might make. And now we're going to dive a little bit deeper here, thinking more about how we can change the design and implementation of value-based care to really achieve some of the goals that we have for it. And we've already hit on some of those issues in the last panel, especially when we started talking about benchmarking. So everybody should be primed and ready to start talking technically, but also thinking a bit more strategically about where we want to go. So let me join here, especially now that I might. And I want to introduce, we've got a great panel here today. And one of the advantages of this panel today is that we have folks who are living accountable care or living value-based care on the front lines. So in the middle here, we have Mandy Williams, who is joining us from the Physicians Group of Southeastern Ohio, where she is a primary care provider, both a family physician and geriatrician here. Directly to my left here, we have Mark Gruner, who's a sports medicine physician practicing in the DC area and also co-founded a group called Limber Health. Moving here to my left, actually, Elizabeth, you trained in pediatrics, is that right? And now is the Chief Scientific Officer for the National Quality Forum. And we also have Ken Cohen at the end here, who's the Executive Director of Translational Research at Optum, a practicing physician, an internist, and still sees patients today. So we have a lot of folks here who have been at the front lines and have really seen what value-based payment can do and what we need to do to improve it, to make it even more successful. I think some of the trends we've already noted here is that there are some broader headwinds that are facing accountable care right now. We've seen some commercial payers pulling back on their accountable care models, either entirely or maybe shifting an emphasis. We've seen a number of other challenges, like we talked about with the healthcare workforce, that it's been a really rough last several years. And we've seen a number of folks leave the healthcare workforce, and still there's high rates of burnout, stress among our healthcare workforce. And so there's obviously a need to think about how accountable care can help improve and deal with those broader headwinds, and also make sure that we're focusing on things that matter to real people, to improving primary care, improving specialty care that affects real people in the community. So let's jump in. And I'd like to start, maybe we'll start on a positive note. I'm an optimistic guy. And start with Mandy here. Mandy, you've been in accountable care for a number of years here. Wanted to start with you about what do you see that's working well in accountable care right now, especially from a primary care perspective? And then let's think about where we may need to start making some improvements.
Yeah, so, I want to preface this conversation with, I'm just a small town doc from Ohio. So I'm not going to pretend like I have all the solutions for accountable care. But what I can speak to is my experience in value-based care and accountable care. And that's been made possible through a relationship with Agilent Health. And it's been a really positive one. So in the day-to-day, things that have really made a difference in value-based care is, first of all, how are we incentivizing our physicians? With value-based care, we're incentivized for the right reasons. Quality of care for our patients, as opposed to that old school fee-for-service model where we're looking at quantity of patients per day. Under value-based care, probably the most critical thing to me that's made a big difference is time. Time in the sense that I have time with my patients. We're going to actually sit down and have meaningful conversations, talk about their diagnoses, have the time to make an accurate diagnosis, and go through their treatment plan. It's also time in the sense I'm a mom of 3 kids, and I'm able to pick them up from school almost every single day. Another big part is the team-based approach. That means I saw, let's say, Betty the other day. She's a newly diagnosed diabetic. That's overwhelming for her, understandably slow. And yes, I had time to talk with her about it, but she's still going to have questions afterwards. So I can lean into my registered nurse, and she can follow up with Betty afterwards and go through those questions she may have in regards to her treatment. It also looks at social determinants of health. I have a patient who sometimes can't afford food. So I can lean into my social worker, John, who's an angel walking on earth, and he can make sure that that patient has food on her table. Or Chuck, who can't make it to the appointment sometimes. John, again, can make sure that he has transportation. Preventive healthcare is a big part of accountable care. And us primary care docs, we love preventative care because we know an ounce of prevention is worth a pound of cure. And at the end of the day, with all of those things, you can see where, patient outcomes are so much better, patient satisfaction is improved, and of course, provider satisfaction is improved as well.
Thanks, Mandy. And I think you're highlighting that we want to make sure that we're watching how we're actually improving people's care and improving people's lives. And I think you're also emphasizing in your remarks how it's not just about incentives and finances, because that's easy to talk about when we talk about value-based payment, but it's also about unlocking other factors that really can help clinicians on the ground, like freeing up their time, making it easier for them to do the right thing, helping provide other resources like team-based care that are really important. And Ken, maybe I'll jump to you. You also have a primary care background here, but have done a lot of work thinking about the intersection for both primary care and specialty care, which is another big challenge, as Mark mentioned, of how do we start pulling in more of that specialty engagement into value-based payment. Would love your thoughts on what do you see is working well right now with accountable care in terms of primary specialty integration, and where are you seeing continued challenges?
What Mandy just described is an infrastructure that is only paid for in a fully accountable care model, where, as Susan mentioned on the last panel, the premium for that patient is given to the physician group to manage. Once you have that premium, you can then build the infrastructure to provide all of the supports that you just heard about. In terms of engaging specialists, it's something that we have not done well. And that's important because 85% of our total spend is specialty directed, and 93% of the payments to specialists are strict fee-for-service. And the problem is, that you also heard in the prior panel, is that we pay the same for high-value care as we do for low-value and harmful care in a fee-for-service model. And the only solution to that, again, is to move to an accountable model where the physician organization, where the hospital physician system are taking accountability. And part of that involves engaging specialists. Primary care physicians haven't had the data that they need to evaluate the care of the specialists. It's just not there. We refer based on historic relationships, proximity, hospital systems, personal relationships, but we don't refer based on granular data. And probably the most important thing that we've done in the past year is we've taken a very large database of about 250 million lives, and we've been able to create over 500 highly granular, specialty-specific metrics that look at care delivered by individual specialties and subspecialties. And then we've been able to take that information and present it to primary care physicians such that we now are tiering our specialists into the highest value specialists and further down the line. We then created a system whereby when a PCP goes to make a referral, the specialists that they're presented with at the point of care are those highest quality, highest efficiency specialists. Now, they can refer to other individuals, but they have to go outside of the system to do that. And by making that the easy button for primary care, over 85% of our referrals now are going to our high-value specialists. On the specialist side, this has been hard for them. As primary care physicians, we've been transparently measured for 25 years, and we're used to seeing our data out there. This is very new to specialists, and there's still kind of this deer in the headlight effect. They're not happy about tiering. They're not happy about sharing their data with primary care, but I can tell you it's a very potent change agent. And the other thing that we're doing is we're taking that specialty-specific data and we're now building value-based compensation models where we begin to pay specialists based on the value they provide rather than the volume of widgets that they're billing for.
Thanks, Ken. And I think you're highlighting here just the amount of infrastructure that we need if we're going to do accountable care right, and for it to be successful, that it's not enough just to change the way we pay. You know, that's in some ways the easy part. You write the checks differently. What is harder is thinking about how you provide that infrastructure, the data, so that the practicing clinicians have what they need in order to be successful. And I think you're also noting here the transition period we're in right now and engaging specialists. And in fact, Mark, we're going to turn to you then about this. So I think as Ken mentioned, we're talking about 85, 95% of the healthcare and spend in this country is determined by specialists. Specialists are a large part of our physician workforce, and yet they haven't been as engaged in accountable care as we'd like today. And so would love your thoughts on, how can we better engage specialists in more longitudinal care for patients, especially for chronic diseases where these are long arcs of relationships. And would value your thoughts about what's going well and where there's some challenges that we can improve on for the future in accountable care.
Yeah, well, I think the first thing is CMS has released to ACOs BPCI data. So if you get into a procedural episode, there are now primary care doctors that have access to the cost of care for different specialists for different procedures. And I think that, and I am a consultant for the state of Maryland, where we have 60 specialty episodes that exist under the whole state, which is an ACO, and it's been very successful. We saw $38 million in savings this year. That just came out recently in our specialty care programs. But there's a couple things that are, I think, critical to improving specialty care involvement. One, we have to think about these chronic condition episodes. So currently, if you're a primary care doctor in ACO, you get access to procedural-based episodes, but these condition-based episodes, which have been tough for attribution, a lot of primary care doctors and ACO leaders don't have access to. So one option is some of the work that Kenneth has been doing. I think that's been great work. The second option are there episode groupers. One example is a nonprofit entity called PACES, which have taken over 1,000 specialty episodes, and it's led by Earl Steinberg, where he's broken down into condition-based episodes that could really fit nicely into an attribution model. And so I think identifying the data and being able to look at the data of which specialist to partner with is part of the recipe. Then you have to have meaningful specialty episode models. You could have shared risk pools. You can have different incentives, like there in the state of Maryland, there's these shared savings episodes, but you need to have some type of payment model to engage the specialist. But what I think And what I've noticed across the entire state of Maryland, whether you're a hospital group, orthopedic group, or any specialist, is their challenges with the data to date. So they need to be able to feel comfortable managing risk, similar to how primary care doctors are starting to really become more comfortable managing risk. But they need to manage risk for just what's important to them. So that procedural episode or that condition-based episode. And they really lack data on who's in the model. And then secondly, they lack data on what is the exact risk on that patient. And without having that data at the point of care for specialists, it's really hard for them to participate in a meaningful way, which they really do want to across the country.
And I think you're bringing up a good point here, Mark, on we don't necessarily have the models we need right now in terms of value-based payment models for specialists for more longitudinal relationships. And that's been some work that West Health and Duke have been Margolis have been doing together. And clearly there's more to be done and really to be able to provide those models that will allow specialists to be more engaged. Elizabeth, I'm going to turn to you, and definitely this is last not least, in that quality measurement and the ability to measure underlies all of this. I think everybody has mentioned that in their remarks kicking off, is that we want to, in order for accountable care to work correctly, we need to be able to focus it on what matters to people, and that's through the measures that are there. So can you talk about where are we right now with measures that are there for accountable care, and how do we get to those measures that matter that can be included in the next generation of accountable care, is where we want to go?
Yeah, we are approaching this from a broad national perspective. The National Quality Forum sits in the middle, the multi-stakeholder convening organization, and we're really trying to drive consensus and trust in the measures that we build. So if you look at measures that we have now, we do have a lot of measures. I felt, a number of the claims-based outcome measures when I was at Yale Center for Outcomes Research that are used by CMS, like readmission measures. But these are, I'm not, okay, yeah, tell me.
Can you hear me?
Great.
So much easier. Okay, I'm going to start over. Sorry, I'll go fast. So I'm speaking from the perspective of, driving policy at the National Quality Forum, which is a multi-stakeholder convener, and we're driving for broad consensus on and trust in the measures that are out there and transparency on the methodology. The measures that we have now tend to be less outcome focused, less focused on some of the outcomes in particular that matter to patients. For example, improvement in clinical symptoms and functions after elective procedures. And they are more focused on areas that we were able to measure early on with readily available data we could get our hands on, like readmissions. And I was just noting that I developed some of those measures in my previous role as a measure developer supporting CMS. Where are the gaps? Those gaps are in those more important next-gen measures that go directly to not just what patients care about, but what, as you were talking about, what providers really care about, what they expect to get out of these procedures, the improvements they are driving towards, and also in these specialty areas. So what we're doing at NQF now is we're trying to make progress on those measures, and we have basically three parts of the strategy that we're using. The first is to identify those measures by getting patient and physician input, but also prospective alignment from payers and value-based payment program developers, I'll just say, the broad ecosystem of people driving policy here. And the reason is, if we don't get prospective alignment on what measures to use, we develop measures that are for one-off use in individual programs. We can't use them across programs, and they're not, it just adds to so many measures and the use of unaligned measure sets by VBP programs, so that providers are seeing slightly different or very different measure sets across the payers they have to deal with, adding to their burden. And in addition, without that prospective alignment, we're not focusing on what really matters. The other thing we're focusing on is addressing the implementation burden to the most important measures. So there are some good measures. We heard mention the congenital joint replacement, CMMI, model, and that helped us test and develop a patient-reported outcome-based performance measure for hip and knee replacements. It helped generate the data. But there are very few measures like that in use because of the operational barriers. Patient-reported outcome-based performance measures have to be built into clinical workflows. You have to exchange the data, aggregate it up. And we are working towards addressing those barriers. So I'll tell you two actual projects we have underway that try to address those barriers. The first is a project that Dana Gale-Safran, the CEO of NQF, started when she took that role about over 2 years ago, called Align Innovation, where we brought payers and purchasers together in a coalition to prospectively identify key gaps in measures that were meaningful to physicians and patients. We focused in this first cycle on a couple of areas: behavioral health and ambulatory behavioral health for mild to moderate depression and anxiety, and also on maternal care. And we're building two measures there, one focused on the management of hypertension during pregnancy and the postpartum period. So areas that were very visible and pressing, and they had no way to evaluate the quality of care. And in building those measures, as I mentioned, we're focusing on addressing not just the technical aspects of measurement, getting to be, valid, reliable measures, but getting to the operational and implementation barriers on the ground. So we're testing them in a broad range of provider and settings. Our payers bring their providers into testing, and we're working through those so that we can implement those measures at scale. So again, setting priorities for measures we're doing, getting prospective alignment, and addressing the implementation barriers as we go. A second program that where we're taking this strategy is, as some of you know, NQF affiliated with the Joint Commission just over a year ago. So the Joint Commission accredits and certifies many healthcare organizations, and they're a leader in driving systems level quality improvement. And it's really, we both have similar missions to improve safety and quality. And by pulling our organizations together, we're able to marry this piece of getting multi-stakeholder alignment upfront, focusing on the right measures, and then building and testing those measures and moving them into use. And in particular, the Joint Commission has said they want to move towards more data-driven, outcomes-oriented programs. And so we can help develop that set of measures and align them upfront so we have more chance of actually moving them forward. And I'll just comment, because this isn't the only way to support, value-based payment programs. Ken, you were talking about, Optum's approach. The difference in the work that we're doing, we're really focusing on measures that have broad consensus, are completely transparent, are not proprietary. We're aiming for their widespread use across these kinds of value-based payment program to raise the level of care. And it's not it's a different way to approach. I'm not saying that these things aren't all useful, but that's the focus that we have at NQF.
And Elizabeth, that's really helpful, especially in thinking about if we want to go to the next generation of accountable care, like hearing from the patient and measures like patient-reported outcomes. We really need to think about how we're implementing that off the bat. And I think that ties into thinking about how we're reducing that implementation burden as well, which goes back to our initial conversation with Representative Burgess, which is we've got a healthcare workforce right now that is struggling. It's been a tough last 4 years. People have been on a marathon. There's been a lot of retirements, folks leaving the system. There's been a lot of stress and burnout. And so we would be remiss if we didn't think about how accountable care can be useful in helping to address those sort of workforce issues. And so maybe, Mandy, I'll start with you. How can accountable care be a solution? Because right now we've talked a lot about reducing burden, but that's not necessarily a positive message of we're making life better. And so we'd love to hear your thoughts from your experiences.
Yeah, love to share. You're absolutely right. The healthcare workforce is struggling. We recently celebrated National Physician Suicide Awareness Day, and we're still seeing 300 to 400 physicians dying by suicide every single year. That's 2 to 3 medical school classes. Along those lines, 40% of women physicians go part-time or leave medicine altogether within 6 years of completion of their residency. 40% within 6 years. I do believe accountable care is a solution to help that struggling workforce. And I think sometimes telling a story can help illustrate that example. So I'd love to share a story of a couple of patients that I'm going to refer to as Bill and Shirley. Very near and dear to my heart. They've been my patients for years. They're in their 90s, been married for 71 years. Shirley has severe dementia, and Bill treats her like the queen that she is. He makes sure her hair and makeup is done every single day. Her nails are done every single week. They are favorites in our practice. Literally, the fish in our aquarium are named after them. So under this value-based care model, over the years, I've had that time to sit down with them and talk about their goals of care and their advanced directives. So when I received the devastating phone call a couple months ago that Shirley had fell and she broke her hip, I knew based on those advanced directives that she did not want to be hospitalized. She wouldn't want that unnecessary surgery. And so through that team-based approach, I was able to reach out to the hospice nurse, and they swiftly went to her home, and she had minimal to no suffering. Bill loved to sing to her. He literally serenaded her until the day that she died. And I genuinely believe that had she been under the old school fee-for-service model, the last chapter of her life would have been different. And I, as a provider, am so blessed to have been a part of that final story. And I feel that value-based care has really brought back purpose and fulfillment to the practice of medicine.
That's an incredibly moving story, Mandy, and thank you for sharing that, because I think you're right. It's the more that we can think about how to make healthcare tap into people's implicit motivations, because folks want to make healthcare better, they want to make care better for their patients, and it's about removing the barriers that exist to doing that. And so the more that we can think about, take some of these technical discussions and really focus on the stories that you tell, the more that we can do that. I want to open up to the panel. Are there other folks on the panel who want to talk about how the healthcare workforce might be a part of some of the next iteration of value-based care, and where we might be able to better support the value-based the workforce that we have now?
I'll take a first crack at that, Rob. Primary care is all about taking a 20-hour day and trying to cram it into a 10-hour day. And how do you support primary care in that endeavor? And it comes back to investment. And as you heard on the last panel, we're underinvesting in primary care. But again, one of the ways that you can invest in primary care is in a fully accountable care model, because you've got the entire premium. And in fact, when you use that premium wisely, spending dramatically goes down, because you're eliminating low-value care, you're eliminating hospitalizations, you're eliminating unnecessary procedures, and you can channel that funding back into supporting primary care. So for example, we're now using AI-empowered ambient listening to create encounters so that physicians don't have to dictate. That takes an hour off of their day. The next step of that is going to use that same ambient listening now to complete orders. So at the end of that visit, if a physician wants to order an antibiotic, an imaging, and a referral, just by stating it during the exam, will actually complete those orders. Another huge reduction in clicks. The value-based infrastructure that supported what you just heard, those individuals are salaried, and it consumes revenue, and that revenue needs to come from somewhere, and it is not supported in the fee-for-service Medicare model. That revenue does not exist. So to be able to have health coaches, intensive case managers, social work services, embedded behavioral health, embedded pharmacy, transportation, meals, all of that takes money, and that money comes from a value-based care infrastructure. So that ability to support a holistic ecosystem around primary care only exists in a fully accountable value-based care model. And it's just a really critical concept for the audience.
And Elizabeth, I think you want to jump in here too.
Yeah, I'll just add, a part of the burden has been quality measurement and the need to aggregate data and cover the cost of building that infrastructure to pull that data together and submit it to payers, public and private. So we're working really on the infrastructure we need to try to generate that data in the routine course of care and minimize physicians' need to engage with it, and at the same time provide back to them, as you're already doing, information that's useful to them in their practice on a more timely basis. So that gets as mundane as working on, new data standards. For example, NCF is working with the American Medical Association on a project to advance data standards for symptoms, which aren't recorded in a standardized way. And then extending, towards using new technologies, how can we use AI in a way that's transparent, fair, equitable in our quality measures as well to extract data in a way that doesn't burden providers. So we're a piece of that, not apparent to every practice, but definitely apparent to many practices.
And since we're talking about data, I think several folks have mentioned that data is really key here in order to succeed in value-based payment arrangements. I think we also know that in order for a healthcare system and a healthcare organization to succeed in value-based payment, they need data on where to do their referrals, where are there opportunities for improvement, what are the needs of their patients, and how do they better meet those needs. And I think there's some struggles right now with the current data that are available. There's obviously value-based payment has helped unlock some sources of data, especially claims data back to practices, but there's clearly a lot more that you'd want, especially in thinking about specialty care utilization, specialty care referrals and the like. And maybe Mark, I know you've done some thinking about this, of where the next generation of data can be that can help support better accountable care.
Yeah, so I can speak to the state of Maryland again, and I can tell you some real life stories and examples that might resonate with you guys. The first is when you think about data, we have in the state of Maryland, we have this Maryland primary care PCP model, and then we have these 50 bundled specialty care models. So I practice in a large orthopedic group. Primary care docs in my area, Montgomery County, don't know which specialists are participating in the value-based care model. So either by creating a geographical, clinically integrated network where the primary care doc knows which specialists are participating in specialty value-based care models, I think is really important. So getting that data to the primary care doctors is critical. Secondly, as a specialist, when we go in and look at the data, so we participate in about 8 procedural-based episodes, and then we also have 4 different condition-based episodes, including a subcapitated MSK episode that I helped develop. And if you want to go and look at your benchmark data to figure out where are the clinical opportunities for you to be successful in a value-based care model, you have to go into CRISP, which is our health information exchange. You get this very raw, dirty claims data. And unless you have really expensive people on your team, it's very hard to look at this claims data analytics specifically for the specialty episodes that you're involved in. And so there are real problems for, you can do site of service changes by moving a surgery from a hospital to an ASC, and we've seen incredible savings from things like that. But if you really want to get into the next care delivery for specialty value-based care, it requires us to look at that benchmark data, break down the clinical opportunities based off the data and the benchmark here, and then be able to develop care delivery models where we think the biggest value is for us to be successful in these value-based care models. And so knowing which patients are in the model and then what are the clinical opportunities and the benchmark data are critical for us to understand the ROI and for us to understand where we want to invest dollars in care delivery. And so I think those are some of the challenges that exist right now in the state of Maryland for specialists that want to participate in specialty value-based care models.
And given timing, I'm probably going to move us toward the end, which is I'd like to ask each of the panelists, what is your top priority, or what would you think is the top priority for accountable care, say looking at 2030? We've got some ambitious goals for accountable care to be, reach almost 100% of the healthcare system by to that 2030 goal, and that's only 6 years away. So maybe I'll start, Ken, with you and work this way up the panel, but what would you say is your top priority here?
It was touched on the last panel in this concept of what is mandatory. If the goal is for all beneficiaries to be in accountable care, our healthcare system has bifurcated, and over 50% of physicians are now employed by hospital systems. And not all, but most of those hospital systems really have little interest in moving into a two-sided risk model. So if we're going to be successful, some form of mandatory movement into two-sided value-based care needs to occur. And frankly, the concept of Medicare Advantage for all, I think, given the data that is available, is a pretty enticing concept.
Elizabeth.
Yeah, if we do that, we need to be able to measure the value, and the quality is part of that calculation. And there, we need transparent measures with a broad consensus that are valid and reliable. that not only the primary care doctors and the specialists can see, ideally that patients, consumers can see as well. And we have not gotten very far down that path of having usable information for consumers to help inform their choice. So our goal is to enable value-based care that drives improvements through better measures, but more important than just getting those measures done is the uptake and use of those measures by all of the parties that who can make better decisions once we have them.
Mandy?
Yep, for me, what bubbled to the top is payment reform. So again, reimbursing based on value-based care, quality of care, as opposed to the old school fee-for-service quantity of patients that we see. And I know everybody has their own comfort level when it comes to risk, but I do believe the ultimate end goal is full risk, because that's going to be what moves the needle the furthest in regards to quality of care and reduction of that cost.
And Mark, you're gonna have the last word.
Yeah, so I think we really need to include specialists in these value-based care models. I think we really do need to have them being part of an ACO, and these need to be subcapitated episodes. So we really have to think about episode groupers that could be implemented by primary care doctors so they can get the data of which specialists to partner with, and then help provide specialists with the data so they can be successful, because if they're in the dark, they're not going to be able to really contribute in a meaningful way into especially value-based care models, which will be helpful for any accountable care organization.
I want to thank the panelists today. And we've had a good conversation both on the technical aspects of how we might improve accountable care, but also how this actually may impact real people and real patients and real clinicians on the ground. So we're going to take a quick break. So for the last panel, we talked about where we can improve the design, the implementation, and feel free to have a seat, folks. Design, implementation of accountable care and accountable care models. And clearly one of the key areas and ways to do that is to have a better system for learning about what works, what doesn't work. And if we have that in place, then that helps us know and be much more thoughtful and evidence-based about how we might change incentives, how we might change the supports that are in those models, how we might change the implementation that's there. And so I'm excited to join this panel today, and I'm going to transition over to the seat. And we'll introduce folks. I'm not remotely going to my on microphone. Did you turn it? I think you turned it off. Oh, I turned it off. Then we will turn it back on. All right. So I'm excited to introduce the panel here today. We have a good set of folks, starting with to my left here, Peter Margolis, who directs the James M. Anderson Center for Health Systems and Excellence at Cincinnati Children's. Oh, I'm not on again. Here we go.
Batteries. Hold on.
Wait, how about now?
Oh, there we go.
All right. To his left is Kathleen Newman, who leads the Camden Coalition, but has a long and distinguished career thinking about evaluation and improvement. To her left is Will Schrank, who most recently is a venture partner at A16Z, but also has a long and distinguished career, including at CMMI and helping set up their research and evaluation infrastructure. And to his left is Dawn Alley, who is currently with Impact Care, and she's head of scale there, but also has had a long and distinguished career in DC and in terms of evidence and improvement. So, you know, I think we've got a lot that we can explore here as we think about ways to improve learning and be able to promote rapid learning, rapid evaluation. And really, this is work that West Health and Duke Margolis have been doing together, and involves in thinking about, well, what are we trying to test here? Are we trying to test big models and trying to see if this entire model is improving? Or are we trying to think about what parts of models, like adding community health workers, would really make an improvement in healthcare outcomes? Are we thinking about how we test? Do we need to do very formal randomized controlled trials? Is it finding control groups? Are there other methods that we can use to test? And then who's actually doing that testing? You know, like, how are we building those learning networks? Because I think we've got a lot of experience that there's a lot of value from those learning networks, but it's exceptionally hard to be able to build those learning networks. So let's dive in with this group. And Will, I'm going to pick on you to start. So you led the CMMI Rapid Cycle Evaluations Group as a center, and its evaluations were really getting off the ground. Reflect on that first decade of time at CMMI. What have we learned so far, and what's working in evaluations and in assessment and learning, and where do we need to go if we're trying to achieve this broader vision of accountable care and make the experiences that Mandy highlighted in the last panel, the experience that everybody has?
Thank you for that thoughtful question, and I'm super excited to be here and to help flesh out with this awesome group some of these really challenging questions around how to learn better. I think it's important to recognize that the context in which we built the original evaluation group at CMMI is different than where we are today. At the outset, that statute, the CMMI statute, was this beautiful jewel that suddenly allowed the agency to test and learn, and if something worked, you'd be able to scale it without requiring some sort of through rulemaking rather than through legislation. And that created this vehicle that was unbelievably appealing, unbelievably exciting to be able to go faster and to be able to learn in real time and make real-time changes in the structure of CMS payment. I think it was early in this transformation towards value-based care, and I think there was some hubris, some overconfidence that if you build the right payment model, that within a relatively short amount of time, providers would just know how to do it. And that there's some, there's a switch you flip, and you're like, oh, now I know how to really take care of people with diabetes, or now I can take care of really complex chronic patients. And the truth is, it's hard. It's hard taking care of complex chronic patients. It's hard fundamentally transforming one's practice to be able to manage the health of a population better. And as essential as the payment model is, the payment model is certainly not sufficient. You put in a new payment model to give the providers the flexibility to test and learn the stuff that they have to do that allows them to successfully deliver better care, better outcomes, and lower cost. Our evaluations at the outset were really testing those payment models. What's really important is to be able to test what the providers do that works, to be able to create that switch to flip, to be able to say, well, what's the evidence that we can distill to say this is what's ultimately the most important part of how to care for a population of patients that's going to deliver better care, better experience, better outcomes, and lower cost. 12 years later, we're now on the other side of what is, without a question, the greatest, most extraordinary experiment in payment that we'll ever see in the world, right? We'll never have an opportunity like this to fundamentally just totally turn on its head the way that the government will be able to just test all of these new models and fundamentally change how providers are paid in a whole host of different ways. It is incumbent on us, it is absolutely essential that we don't just do these binary evaluations and say, does this model work or does this model not work? Because that isn't the learning. The learning is within those models, what works? What's the magic in the model? What's the thing that providers can do if given the flexibility? What are the things that they can do that actually can really drive the outcomes that we care about? I will give all the kudos in the world to the current CMMI team for recognizing this and to emphasizing this transformation agenda idea and a real deep commitment to trying to learn how to study within models, to study across models, and move away from these binary assessments to a much more holistic sense of like what works, what doesn't work, how do we cultivate, how do we curate, how do we harvest those, and how do we scale them? And ultimately, that's that intersection between, and this I think was built beautifully 12 years ago, that intersection between an evaluation group and a learning and diffusion group that when working together effectively can allow us to scale the good stuff much faster. So I know that was a longer answer than you had anticipated, but I do think that sort of that context, that evolution over the last 12 years is really an important place to start.
Well, and Will, I think what you're noting here is that at the beginning of the Affordable Care Act and the introduction of CMMI, we thought that we would be able to put a model and say, does this work, not work? And then you would go and scale. And I think what we discovered is, and as you noted, like implementation's hard, and just changing the way that you're paying doesn't mean that necessarily a provider system is going to be able to instantly go, well, do we need to implement a paramedic, home paramedic system where we are going to send paramedics to the home to do visits, to check in on complex patients and see whether they're doing well. And frankly, we don't necessarily even have the transparency in some of these cases to know, like, what are the care innovations that, say, an ACO is using as they are thinking about trying to manage their population. And I think that implementation point, maybe I'll turn to you, Dawn, that it has been really challenging to implement many of these models. There's a lot of areas that have to be thought through: leadership, change management, buy-in among the healthcare workforce. Can you talk a little bit, based off of your experience at CMMI, but also your experience in your current role, about what are some of those implementation factors that affect success, which ultimately tie into learning and figuring out what works and what doesn't?
Thank you so much. And thanks for being here. Thanks, Will, for teeing me up so beautifully. I think we do have to move beyond the up-down, did this work or not? I also want us to be careful in doing that. We should be at a point where we can move beyond questions that are just about effectiveness. But we need to be asking not what works, but how can we scale what works, thinking in implementation science ways. We have, what I worry about when as we have these conversations about evaluating in a different way, is how we make sure that we really are putting attention into reproducibility, scale. At Impact, we talk a lot about creating magic with consistency at scale. And what we're talking about is the magic that happens when an authentic community health worker is creating a trusting connection with a member of their community to improve their health. But that doesn't just happen because you say, I want to start a community health worker program and I'm going to hire some people and they're going to be kind and do great things. You have to put attention into the infrastructure, the clinical workflows. And I think there was an idea early on at the Innovation Center that we would set incentives and provide flexibilities, and then providers would just figure this stuff out and they would naturally adopt evidence-based practice and scale. And I think we unfortunately have just a ton of evidence that that has not worked. One piece, we're not seeing providers take advantage of the flexibilities in many of the models in terms of, some of the benefit enhancements and beneficiary engagement incentives. We haven't, unfortunately, seen widespread adoption of some things that we know improve care and save costs, like cardiac rehab or community health workers, or Capable, an intervention that CMMI tested that achieved a 7-to-1 ROI, and still fewer than 10,000 people across the country have gotten it. We're actually still struggling with some of the stuff we heard about in the previous panel about how do we refer to high-value specialists. And that is incredibly important, but I think it's not what we all envisioned when we thought about the promise of accountable care. We thought we're going to transform the way that care is delivered to improve the outcomes that people really care about. I would argue that so we know that incentives alone are not enough to drive change, and we also know that evidence alone is not enough to drive change. So what does? And I think part of where we have seen success is actually about focus. So in some CMMI models that have been very focused, we have seen remarkable improvements, including, in evaluations. So we have seen a reduction in all-cause mortality with no increase in spending in the Million Hearts model. We have seen that said practices, we're going to really have you focus on reducing cardiovascular risk. In the Accountable Health Communities model, where we said we want to screen for health-related social needs and provide navigation around them, we've seen a reduction in emergency department use. In Medicare Care Choices with hospice, in even just having a really concise measure set, and the fact that we're now seeing more than 50% uptake of annual wellness visits. So when we get really crisp about what we want to achieve, we know it is possible, but that is not necessarily what we're seeing, day in and day out. So again, I think this is less about what works and more about how we scale it. I love the idea that CMMI has been looking at of this cross-model learning and focusing on, opportunities for focus on how we scale interventions that work. And I think that approach can help both providers learn and help CMS learn. And so I'm going to share one example of the kinds of things that could unlock. One of the health systems that we work with is Essentia Health, large health system in the upper Midwest. They are living the value-based dream with more than 50% of their revenue in value-based payment models. But that is across 32 different value-based payment models that they participate in between SSP, primary care first on the fee-for-service side, Medicare Advantage, Medicaid value-based payment models. And so then they're on the ground saying, I just want to operate a community health worker program in primary care practices that can serve everybody that walks into the door in the same way. And essentially, they're now braiding across those value-based payment models in a way that's not so different from a community-based organization trying to braid across grants to just figure out how do I support these team members. And then, so once you actually understand what it looks like trying to implement these things that we know work on the ground, I think that actually takes you back to some of these policy questions of like, well, should we look at a benefit enhancement that would allow elimination of coinsurance on community health worker services as one example? But you really have to get into the nitty-gritty of like, what makes this so hard and why is it challenging to scale in order to achieve progress?
And Dawn, you brought up a number of really important points here. I think one of the things that I'm latching on to is just how important it is to have that network on the ground that you can draw from to understand even how can the model be successful. As you point out, like waivers, some waivers are not being used, and there may be a really important care delivery reason why, say, like a post-discharge home visit waiver isn't being used because it has to do with referrals or finding the right patients, and being able to have that type of a network that it helps you to understand very quickly and then see where you can improve the model is so important. And I think that's a great transition to Peter here. Peter, you help run a number of these types of learning health networks and help think through how do we really expand the scale of how we can learn here. And so based off of your experience in Cincinnati Children's, can you walk us through what does it take to actually stand that up? Because I don't think it's easy.
It's not easy, but it's challenging and a lot of fun. So as we all know that complex problems in healthcare can't be solved by individual organizations working alone. And much of our work has been focused on methods to build continuously adapting systems that improve outcomes at scale by engaging large communities of people and working together. So we call these learning health networks. They bring together what we call people, patients, clinicians, researchers, and organizations like hospitals, community organizations, nonprofits, schools to collaborate at scale towards shared goals of improving health. So in a learning health network, everyone works together to identify and solve problems. They're not a new technology. They're a way of building action-oriented communities through collective action. And just as an example, some of the networks have produced important outcomes, health outcomes. So our network called Solutions for Patient Safety involves 150 hospitals. They've produced a 32% reduction in serious safety events. The National Pediatric Cardiology Quality Improvement Collaborative has produced a 40% reduction for kids with the most serious congenital heart disease, hypoplastic left heart syndrome in 95% of the kids in the country. And our Crohn's disease network has produced a 22% improvement in remission across 2/3 of kids in the country living with that disease. We think of 4 parts kind of as a field guide for building networks. The first is common purpose, collaboration around what really matters to most to people in improving population health. So for kids with Crohn's disease, it's not only getting into remission, but also being able to go to school, play with your friends, have sleepovers. The second is building community, and this involves bringing all the different participants together, patients, clinicians, researchers, clinics, hospitals, to co-design and co-develop as a community the tools and resources that they need. And so right now, for example, we're starting a network focused on people living with bipolar disorder. We have about 50, they call themselves experts by experience, people who are living with bipolar disorder, who have been involved in the development of the measures and interventions like peer support. The idea is to unleash the expertise that everybody has in contributing. The third part is transparent data sharing and feedback loops. And this is data about outcomes, data about processes that are used to guide clinical decisions and make data-driven adjustments to how the scale is going. For example, in the Crohn's disease network right now, we're working with doctors to build dynamic, adaptive, personalized monitoring of drug levels for kids. We have about 10,000 kids on biologic agents across the country. And we're using the data, the doctors are using the data to actually build those kinds of systems that actually have to adjust over time. And then the last is building the systems improvement capability. People need to be equipped with the knowledge and tools to actually change the system. So those four things are what leads to knowledge exchange and know-how at scale to be able to grow and impact.
Thanks, Peter. And Kathleen, I'm going to in the opening questions with you, although I don't think I want to make sure this is not the least person I'm here, and this is very important work for you, which is how have you been thinking about how to improve assessment and design in your own work, recognizing that in many cases the result of the assessment is oftentimes the start of the journey and actually as opposed to the end. So I want to talk a little bit more about how assessment and learning has worked for your organization.
Absolutely. Thank you so much for having me. So I should tell people who don't know, the Camden Coalition was involved in a study of our care management model. The first research of that came out on January 9th, 2020, but who was counting? And there was a null effect of our care management model looking at inpatient. And I will say that I had spent 10 years at the Children's Hospital of Philadelphia. I started a place called Policy Lab, and I was not afraid of a null effect because I thought that the learning came from the analysis and what we could do after. I have to say I was a little naive because at the Children's Hospital of Philadelphia, super easy to get funding in between studies to continue your analysis. I was able to get no funding as a community-based organization to do secondary analysis, but I persevered, and we ended up producing 3 papers that we funded on our own, secondary analysis of the study. We were early adopters of the idea that you should go outside the hospital with a nurse, a social worker, community health worker to actually try to address all the issues that all of us up on this panel are trying to address. And I'm probably here on the panel to tell you that all of that secondary analysis and incrementalism and non-binary approach to research is really the way to go, because if you look at the 3 papers that we published post-RCT, what you'll see is that we were able to actually look at intermediate outcomes. And one of the papers, actually our original researcher, MIT, joined on with us. So we were able to show that our group compared to the control group compared to the intervention group did have a statistically significant difference in terms of connecting them to primary care, did have a statistically significant difference in terms of connecting them to specialty care, did have a statistically significant difference in terms of connecting them to DME and to SNAP. Those are not unimportant things. Can a care management model in 90 and 120 days for the most complex group that had been studied reduce inpatient? We found no. We also found when we did secondary analysis that neither group, either the control group or the intervention group, had any, and I mean any, I'm talking no, home care. There was not an instance of home care that went to anyone in this group. You had to have at least 2 chronic medical conditions to be in intervention or control, and you had to have a couple of social factors. We call them complex health and social needs. This is really, really important. And I am delighted that our research is now looking deeper at these types of things, and couldn't have more to say about that. The other thing is that 9 years, probably, we started in the middle of our RCT, a Housing First program, because we knew we couldn't help people until they were housed. I literally have people who have had the same community health worker for 9 years. And just was able to sort of do our own data analysis of that. And the findings are phenomenal in terms of pre-housing and post-housing and what you can do. I will tell you, you can reduce ER admissions. You cannot reduce inpatient. You can reduce it a little bit, but not a ton. And that's probably because we need the primary care models and the physicians in on this in a different way than we have them in on our model, I will tell you. The other thing is that we knew from our secondary analysis that the people that we were unable to engage, and I am talking that our best community health workers were unable to get them involved in our intervention, was anyone that had one arrest within the previous 6 months. Impossible to engage them. And what we now have is a medical legal partnership where our lawyers are embedded in an addiction medicine clinic, trying upfront to actually figure out how to deal with their criminal law issues and addiction at the same time, because that combination was the most difficult for us to engage. And we are looking for research partners on all of this because we're looking for rapid RCTs. We don't want to engage again in an RCT that sort of took as long as it did. And we also only want to engage with people who are interested in secondary analysis, intermediate outcomes, that type of thing.
And Kathleen, you bring up a really good point here in that we can learn about a lot of things here. And some of the early views of accountable care was, you look at, does it save money or does it not save money? And you have some quality measures sprinkled in, but those may not be the quality measures we all really want to move toward. And on our prep call for this panel, we talked a lot about where we want to move to those measures that matter in improving and learning. So maybe I'll throw this open to the group, and I suspect many of you will jump in. So what should we be including in these sort of rapid learnings and these rapid evaluations, these rapid assessments? What would be the markers of success for these types of accountable care models? And maybe, Dawn, I'm going to turn to you and then walk down the row.
Sure. We have to find ways to measure whether patients are achieving their goals. The most work that's happening on this right now is in the long-term services and support space, but wouldn't all of healthcare be better if our relationships with our clinicians were focused on whether we are achieving what we want? And whenever we say we're going to measure, are you referring around health-related social needs, or are you doing this on behavioral health? What we do is end up fragmenting in different ways. So we have to look at those kinds of patient-centered measures.
I'll build on that fragmentation point. I think if we were to try to prioritize the things that make it hardest to deliver good quality care for complex patients in the US, it's the complexity and the fragmentation of how the care is both paid for and how it's delivered. And we have to get to some better measure of integration. We have to get to some better measure of how the team cares for a patient rather than in a bunch of individuals each caring for a patient. And I think it'll build precisely on what Dawn was getting at.
Kathleen, I think you already hinted at some of these measures in your opening remarks, but other ones that you would add?
Yeah, I mean, we really pay a lot of attention to continuity of care. And does a person have the same team caring for them? That's really, really important. The other thing that we're asking our patients to sort of clock with us right now is who's answering the phone when they call in on an emergency. I literally need to find out, is the nurse or whoever else is on the other end, are they in our state? because there's so much fragmentation and there's so many vendors involved now in terms of answering 24-hour call centers that we sometimes believe that the people on the other end of the phone actually don't know what services are available in our community. And so we are actually tracking that right now because we don't understand why some of our clients are being told to go to the emergency department. Because if their doc answered, they would tell them not to go.
Here, how about you?
I'll just add that one additional thing to measure when we're thinking about scale is context. So one reason why we're interested in these very large networks that have 100 or 150 sites in them is that there's a lot of variation in the kinds of ways in which care takes place. Not everybody gets to go to a hospital like Cincinnati Children's, where we have every specialist under the sun. Some patients are cared for in Boise, Idaho, and they don't have access to that kind of environment, or the doctors have different resources. Being able to measure contextual factors allows us to understand the ways in which interventions need to be adapted and supported to get them into practice in different settings.
And to repeat back, I think what I'm hearing here is that clearly we want to think about where there's opportunities to measure meeting, individual people's goals, where there's an opportunity to look at fragmentation, integration, continuity of care. I think there's also a local knowledge, local context, and ability to adapt accountable care to those different contexts, recognizing that home-based care might look very different in a very rural, say rural Idaho, versus say in the Washington, D.C. area where we've got folks that are much closer together. So I think this is a great list that we'll definitely want to follow up with afterwards. And I'd like to thank all of the panelists for this informative discussion. And clearly, this is a really important topic for how we can improve accountable care, its design, its implementation going forward. And we're going to turn things back over to Mark McClellan, who's going to take us home and think about where we can take all of this.
Great. Again, my thanks too for the preceding panels and for all of you who have been with us today, both here in the room and online. I'd like to ask our panelists for this last session to come on up. We started out with federal government perspective from Congress. We're going to come back to federal government perspective from HHS, with perhaps the most important agency as the last decade of work on innovation and accountable care and payment has gone forward. Come on up, don't be shy. And for that, very pleased to be joined by Dr. Liz Fowler, who is the Deputy Administrator of CMS, as well as the Director of the Center for Medicare and Medicaid Innovation. Liz has been referenced, and CMMI has been referenced a lot today, as you might guess. I'm also very pleased to welcome our close collaborator in much of this work on advancing accountable care, Tim Lash, who's the president of the Gary and Mary West Foundation and president of the West Health Institute and West Health Policy Center. I thought I'd try to summarize the discussion that we've had so far today, but boy, there's a lot to it, Liz, and you're right in the midst of living this now. We heard from, on the one hand, a lot of perspectives around just the fundamental importance of this movement to accountable care, but on the other hand, about some of the ongoing challenges that are leading to, let's just be clear about it, blunt about it, the growth in these models of longitudinal, coordinated, person-centered care is just not on pace to where CMS and this administration and the previous administration would like it to be. And we heard a lot about some of the reasons for that. There's no one magic bullet here. I think that makes it hard. On the other hand, there are some clear ideas around especially changing the benchmarks and the core payment models. We still have a payment system, even as accountable care now accounts for a significant share of the total, especially in Medicare and traditional Medicare and Medicare Advantage, that's pretty much fee-for-service based, and in some ways is getting more fee-for-service based, more fee-for-service billing codes. We heard about the importance of benchmarks that perhaps you've heard about ratchets before and things like that, but getting benchmarks that sort of get it right technically, as Michael McWilliams likes to say, and I still haven't figured out how to explain this to a member of Congress yet, but get kind of that right balance between encouraging participation, still achieving some savings, and it's probably not where we are today. And similar kinds of issues on the Medicare Advantage side, which is risk-adjusted, capitated payment, but it's still in many ways based off of fee-for-service claims and encounter data. We talked a lot about data sharing and how important that is to helping providers figure out how to succeed, and measures that they can use to do everything from identifying effective partnerships without having to consolidate, to maybe making it easier to implement new care models. And among other things that you heard on the last panel, we talked a lot about a different approach to, or I guess I should say an augmented approach to evaluation, where the CMMI 5-year pilot models certainly have a role, and I appreciate your thoughts about the continuing role, but a whole lot of opportunities, especially with better data systems and infrastructure, to learn in more focused ways about how to succeed in models, and maybe about how to improve some of the existing models in ways that maybe don't take 5 years, but could be done on top of a core of accountable care payments for advanced primary care, and augmenting beyond that. And then finally, a lot of discussion about alignment across payers. So that's public and private, it's federal and state, it's different CMS programs as these become sort of the mainstream, and no longer sort of the alternative, but maybe more like the norm. So there's a lot that we talked about today that I'd be glad for you to comment on, but maybe we could just start out, if you don't mind, with some discussion around what you see as the biggest priorities and opportunities. You've been in this job a while, and the last time we talked, I gotta say, working in federal government, it's dog years. 7 years to one at least, especially if those years include election years, and you've still got a lot of enthusiasm and commitment despite the challenges of this work. So what do you see as where we are and where we're headed from the CMMI perspective?
Well, thanks. First of all, thanks for the chance to be here. And second of all, you've now outlined all of the challenges that keep me up at night. But it's also what makes the job so interesting, is trying to solve those challenges. And so you asked, what it is we're focused on. We're focused on the models. We want to drive towards accountable care. We've got ACO REACH. We need to figure out what's next, create a pathway for those innovations, and we're working on that, as many of you know, probably not fast enough. We have the primary care models and PCF and the making care primary. We've got the whole body of work where we're trying to test innovation within the shared savings program. Part of the reason for that is finding a permanent pathway and making it a little bit more predictable what's going to happen. And so PC Flex, Primary Care Flex, is one example of that. And we asked for comments on creating a very high risk model, a global risk model within SSP. So I think we're, in terms of the models, focused on that. I think we're also focused on maybe hearkening back to some of your points on the evidence base and thinking about new ways of creating evidence. And I'll tell you what's challenging. And I think Don alluded to some of this. It's like, these huge evaluation reports that come out 2 years after a model ends, and they show that it's not making a difference, but we know that it's making a difference. Or it starts to make a difference at the end, but by the time it starts to make a difference, the model is ending, and we don't have enough evidence to be able to scale the model. And so we're really thinking about scaling differently and evidence generation differently. And part of that is, if you're reading closely, and I know you are, trying a rapid cycle innovation approach within SSP. So what are those targeted approaches that might work and might be able to be spread quickly? And so I think thinking about evidence generation, but I'll tell you, those evaluations are more and more challenging as value-based care is more diffuse. where do you have a clean control group or a comparison group that isn't sort of, you know, doing some of the things that we're testing. And so it gets harder and harder it's almost like the bar is raised and a catch-22. So we're excited about the rapid cycle innovation and the chance to think about things differently. And then we're thinking about scaling differently. And I mentioned that we're testing within SSP. So there's like a permanent pathway for maybe those innovations that work within SSP, and the things that we're testing, we already know we might have the legal authority to be able to scale them. And I think that's really important. We're also thinking about a quality pathway. So the statute says you can expand if you're saving money without harming quality, or if you're improving quality without increasing costs. There was no pathway for how to scale a model based on quality improvement. And so we have outlined a way to think about scaling based on quality. And then, you know, I think other means of scaling might be, you know, through good old legislation, although we all know that that's harder. And, you know, the insulin model is one, testing a $35 a month insulin. If it works, go back to Congress and say, we think that this can work, and we think there ought to be a way to make it permanent where we don't have the legal authority within the statutes. But you've outlined a whole host of problems. Those seriously are what keep me up at night. But I also think working with West, working with a lot of folks in the room that are really committed to this path forward, we can keep making progress.
Yeah, I mean, it is interesting that for all these challenges, we heard a lot today too, there isn't really an alternative. So it very much behooves us to try to figure out how to do it better. And Tim, I know at West, you all have been involved for a while in trying to create learning and action networks that do something like what I think Peter Margolis was talking about on the last session, bring together groups that have a common purpose of improving care in meaningful ways for at least certain types of individuals or Medicare beneficiaries or certain populations, and try to learn and scale how to do it. How is that work going? Because it sounds like an increasingly important, and you know, hopefully as we get better, more interoperable data and a lot more analytic support, that can be a bigger part of the future here.
Sure, happy to comment on that, Mark. You know, I guess to click it up a level, just as I was processing what was talked about today in the context of learning action networks, it comes down to what are we actually trying to solve for, right? And when we look at what's the impediment to broad system change, you know, often the lack of infrastructure or the lack of payment or profit, you know, that these are frequently cited, right? But I think at the end of the day, people do things because they have some belief construct, whether that's a patient that's looking for everything at any cost at the moment they want it, right down to the color of the stent that they think they need, or it's, you know, the provider saying, okay, I'm doing the very best that I can because I don't believe I have any viable alternative to sort of the status quo. Or you click it up a level to service line leadership or system leadership, you know, whether it's under belief or perception, right? You know, trying to optimize, you know, where hopefully patients are going to have the right outcome, but where they're going to generate the highest present value. And I think Michael commented on that, you know, earlier today, that, you know, sort of, you know, not just present value of a return today, but if you look at a 10-year period, like what am I doing today that's going to optimize on that, right? And so all of that is a function of like, I believe, or we believe, an individual believes something today, right? That drives our behavior. And if we're solving for broader change, like we need people to believe a different thing, right? And so I think it's through that lens that rapid cycle innovation and testing through the learning action networks, you know, really took hold within our investments. And I think some of my colleagues are here. I think we're over 17 systems and risk-based organizations have participated at this point. And you say, so why is that important? And I haven't heard anybody say it today, but like theory of change, it's everywhere. We were at a village movement meeting, and you know, this is, you know, a group of where they're really thinking holistically about what it means to sort of, you know, age successfully in place, take care of each other. And to the villagers, we're talking about their theories of change. And if the villagers are talking about theories of change, you know, it's become sort of the buzzword, right? But regardless of what model you look at underneath that, like the concepts of, you know, being very agile, very adaptable, engaging stakeholders and measuring, right, as you go are absolutely critically important, right? And so as we think about engaging around, you know, some of the solutions, whether that's, alternatives to an admission, or how to think about, home-based, sort of hospital level care, or, anything in between, the opportunity to get people that are trialing it together to talk about why they've been doing what they're doing. What is that belief, right? And then what evidence do they need? What payment models do they need? Like, what is in the way, right? For this to be, for change to be adopted, right, in a sustainable way is really, really, I think, critical. So as I think about, Liz, what you're doing, and Mark, what you're doing, the ability to find a much closer integration and intersection between where some of that real pragmatic work and learnings, can occur, and then breathing it in both directions. What have been some of the intended consequences and unintended consequences, both positive and negative, of some of the trials, right, or demonstrations, and then are there learnings from some of the broader experiments that have happened that could be they could accelerate, some of the point projects that might happen within a learning action network. But I really do think it comes down to sort of a fundamental shift at every level, which is why it's so hard of, what people are operating under today, perception or reality in terms of what they believe, right? And then moving it or shining a light on, a new belief construct, which will drive different behavior at every level of the system. And payment is really, like the very sharpest point of a payment model, right? And policy is where it meets the health system and the patient. And it can cut in a positive way, and it can cut in a negative way. But you got to get in there and study it, to do that. And I think the LANs, or learning action networks, are useful ways of doing that.
CMMI has its own healthcare payment learning and action network, which we at Duke Margolis are very much involved in as well. And it's interesting, that effort, I'm going to oversimplify a little bit, but I think this is fair, started out with a focus on, okay, we want to get these payment reform goals adopted, more people into so-called advanced alternative payment models and the best ways to measure that. And as the work has progressed, it's increasingly broaden the focus to kind of incorporate the things we've been talking about here. What is it that the payment reforms are really intended to accomplish, and why would a particular new payment model help get there? Reducing burden, increasing care coordination, more continuity of care, affordability, all the things that people care about, so that that effort is now, I think, moving in the same direction. Tim mentioned 17. I didn't realize that. I didn't realize we were such a small part of the West portfolio, but 17 learning and action networks that you're already funding. Thank you. There are other efforts underway, around pregnancy and maternity care. I could go down the list, but those seem like they haven't yet been kind of aligned or coordinated with what you talked about you want to see happen next, which is, and what we heard about on the last panel too, sort of more focused support for finding, whether it's, what are you all calling them, positive deviants, or something like that, the ones that are successful, the things to do if you're going to, why are we doing this payment model? How does that connect to what really motivates people? And are we at an inflection point here, maybe? That's an overused term, but there are a lot of networks out there. There's a lot of need, as we've talked about today, for accelerating the ability to succeed in alternative payment models. And by the way, as you found, that the model that's in place 5 years from the start date is not the model you started with in terms of benchmarks and payment designs and all those kind of data sharing, all those kinds of features too. Is it time to make this more systematic, and can we do that quickly?
Yeah, that's a really good point. And I completely agree. It's a complicated landscape. And as we looked at, we started out thinking there was this opportunity to create, for meeting our accountable care goal. We've got an advanced primary care track. If you didn't want to join an ACO, we've got all these options for accountable care organizations. Sometimes we're targeting the same organizations, and they have multiple opportunities and lots of people reaching out to them and saying, come join our organization or work with us. But there's still 45% of those practices that aren't in anything. And so I think we're not necessarily getting the results we want, because we're sort of overcomplicating it with maybe too many options. So I think we need to simplify, and then we need to figure out how to really reach those organizations and practices and clinicians that aren't in anything right now. And part of that is, and Congress is engaging in a whole discussion about looking at physician payment. And we welcome that conversation because you need the push and you need the pull. And I think there's opportunities there to think on a bipartisan way to maybe encourage that movement a little faster, reach those organizations and providers that aren't in anything and in value-based care and haven't been touched. And then I think on our part, we need to simplify it. And I think that means administrative simplification, and the administrative benchmark may be part of that. We could get into the conversation about benchmark. I'm looking at Michael McWilliams, who has been advocating for that, and for good reason. I think we think there's a lot of merit into that, but really thinking about the burden too that we're placing on providers and sometimes on patients too. So there's a lot of, so now we require screening of health-related social needs, and this is getting back to a point that Don made about, and maybe another example of scaling. Accountable Health Communities ended up being a successful model. We have built that screening tool into all of our models, but now what we're also finding is patients get asked all the time by more than one community health worker and more than one provider, are you hungry? Do you need help? So we've come up with maybe now a more complicated system instead of simplification. So we are at an inflection point, and I think we're at the point now where if we don't really lift up, to your point, click up and really think bigger picture about where we're going, I think we risk not making more progress, and which is our goal, of course, in all of this, is to continue to make progress.
Yeah. Tim, thinking about where we are, progress to date, where we're going, anything else that you'd highlight before we wrap up about opportunities for accelerating progress?
If I think through the lens of the land, some of what can come from it is what rapid learnings can inform what is working, and that can go in both directions. But what we have now is not sustainable, right? And so, back to, sort of the beliefs and what people are doing, and it's really complicated. I think some of the learnings from some of these demonstrations can be what will never work, right? And if we're trying to meet everybody where they're at, right? If we're trying to meet the patient where they're at, the physician where they're at, each health system where they're at, any, sort of other type of risk-based organization, where they're at, we're going to end up with, more models that are sustainable. And I'm not sure, I'm not sure we have the time or the energy, right? When you just look at the growth of, of spending, and quite frankly, the outcomes that we have, right, in this country, right? And so if there are ways to accelerate not only what can be tried and what is working and, what you double down on, but, sort of, Liz, I love the word simplify, right? I mean, do I think we're going to head, and Michael and I were talking about, McWilliams, we were talking about this the other day, we're going to end up in a place where, we're fully capitated at the government level, where real decisions around value at a population level are just decided, i.e. we're willing to pay this much for that and for you, and we're not willing to pay it over there. I don't think, I don't think near term we're headed in that direction, nor should we, given the system that we have. But, at some point, I think we need to be, sort of more declarative in terms of where we're going to be, which resolves some of the ratcheting and spillover and just, sort of conflict in terms of real return, right, that I think a lot of systems, are facing. But it also, gets declarative in terms of where we're going. Liz, you and I were talking about this. If the Fed, was, ambiguous in terms of what its monetary policy was going to be, and interest, I mean, the markets would be all over the place, right? And so, I think healthcare is no different. As we have a sufficient number of learnings in terms of what can work, I think, more simpler, larger, mandatory, and at some point, the system meeting where the country needs us to be, right, to cut the tension between quality and outcomes for a patient and the same at a population level. Because, increasingly, I'm very nervous, Mark, that when you're in these discussions, it almost feels like we've taken a journey on value, we've gotten lost, and in some cases gotten disoriented. Now, I know you guys are working hard to sort of get at that, but it's an unfortunate term that we throw out, sort of, all over the place. And, I think, certainly we all want what's best for sort of patients and a quality outcome there. But the overall spend that we have, has to be ratcheted, down as well.
Oh, yeah, I definitely want you to say something on this. Let me just say, and don't misquote me on this, but while macroeconomics is definitely not simple, the Fed's job is in some ways easier, right? There's one tool they have, or one main tool they have, and then a couple of metrics that are sort of clearly really important for what to do with that one tool. Your job is more complicated, and appreciate the response, but if you could highlight, looking into 2025 and beyond, what are the most critical, maybe simplification themes for where these payment reforms and supports are really going, and how is that evolving in your portfolio and more broadly? I know as you mentioned earlier, you're working more closely with the Center for Medicare. You've got new programs that are working with states and Medicaid reforms across, making care primary across all public and private programs. Yeah.
Well, first of all, I think there's a great opportunity to start working more closely together, and would love to explore, like, as we look at our rapid cycle innovation model, maybe there's a way to actually have a public-private partnership here. So I would welcome more chances to work together. I think that is one direction. But I do want to, like, I do think there's a reason for optimism and a hope for the future. And yes, we have an unsustainable healthcare system, but it's not as unsustainable as it was in 2010 when you look at the trajectory of spending. For some reason, we have not been spending as much on Medicare and Medicaid as we thought we were going to in 2010. It's in 2019, looking back at the 2010 estimates, the baseline estimates from CBO, we were about what, 17% lower, or some pretty significant number. So something is happening that is moderating some of these cost increases. So and so I want to also mention, we are looking more closely at some of the spillover effects from our models. Again, this is what makes the evaluation so difficult, but we are starting to look more closely, and could we actually measure that spillover effect when it turns out that what we're testing is being spread and diffused more broadly, but we just weren't picking it up in the evaluation. So I think we're trying to do a better job of all of that. You asked about simplification. I think there's any number of things we can do. And as I meet with stakeholders in our models and providers in our models, and I go across the country and meet with them and do site visits, it strikes me as how complicated things are in terms of all the data feeds they're getting from all these different sources. The attribution model, thinking about, we changed the goalpost. We started out over here, but by the time you get over there, there's a retrospective trend adjustment, and it turns out that you didn't meet, you didn't do as well as you thought. We can't do that. If we want to make better progress, we need to have a more predictable approach too, and more clarity in our rules. So I think there's a lot more work, and we're starting to think about that too. We're working with the PTAC. I want to give a nod to the PTAC, that we're in those conversations with topics that they take up. And it's part of the land discussions too. And I do want to give a plug for the land. We have our meeting coming up on November 14th. We've almost doubled the number of participants and the work that the land's doing. We have an accountable care collaborative.
A whole lot of work on alignment.
A lot of work on alignment,
simplification
and a national health plan working group, a state transformation collaborative, really trying to take what we're seeing and learning and harness that. And so I want to make a plug for that I think there's a lot to be hopeful for, as complicated and as difficult as all these models are. But I think I do disagree that we need to do. So I like the idea of the rapid cycle innovation and the targeted, like, what's working, and let's figure out how to spread that. But we have sort of moved away from the every specialty gets their own model. We're moving away from that and building a bigger picture that we hope is an umbrella, and it's that accountable care sort of overall framework where we think.
And that's more focused on results that matter for people?
Exactly. And we're trying to think about how we're improving the patient care experience as well. So we're doing patient journey mappings when we actually think about the interventions that we're testing, and what is not working for the patient now, and what is it that we want to improve, and what is the mechanism to get there.
We did have a lot of discussion. I know we're almost out of time, but I want to make sure this fits in with your time with us too, around improving and aligning quality measures that are more meaningful. We talked about patients meeting their goals, which often are around functional status or ability to do something important in their lives. Any comments on the quality measurement and getting to alignment, more meaningful measures that are incorporated into those care journeys
mean,
and care delivery systems.
That, and you mentioned simplification and administrative burden. Quality seems like a very good place to start. CMS announced this universal core measure set of quality measures that we were going to look at across our programs. That's Medicare, Medicare Advantage, Medicaid, Marketplace. Are we making progress? We have the measures. We know what we want to do. I will say from the Innovation Center's perspective, we still think it might be a few too many measures. We still would like to see fewer measures, not more measures, and a systematic way of retiring measures if they don't seem to work, and sort of refreshing where we want to go and making sure that we're setting the goal in the right place. And we also think we can be a testing ground for new potential measures, especially where there are gaps. So working with the National Quality NQF on their aligned innovation and thinking about
That's with a range of payers as well.
exactly with other payers in the system. And as you know, working, trying to align other payers is probably the most complicated part of some of this work, but we don't, we're still trying.
Tim, we're almost out of time. Any last words, further reflections before we wrap up?
Look, I'm very much looking forward to the partnership and expanded partnership with Duke Mark, and I think we're at a right time where the intersection between some of the rapid learnings, a simpler model, both in terms of the payment and some of the measurements, and signaling that is more longitudinal and stable, is going to yield continued positive results in terms of the overall outcomes. And
Tim, if I could
trajectory
just push you a little bit on this. West has a history of working with pretty much everyone around shared goals. If we have a pluralistic health system, it's going to be public-private. Liz talked about maybe a public-private collaborative foundation for really strengthening these learning networks and the like. Is that something that fits with the West strategy going forward?
I think we all have to co-travel together. If we're going to solve this or step into the opportunity, I'd say it's a challenge, but there's an opportunity I think ahead of us, and we need to do it together.
All right. Well, I wish this was an easier process. I wish there was a magic bullet, but this is so critical for the well-being of Americans and the sustainability of our healthcare system, especially one that's innovative. Really appreciate all of the West leadership on this, and Liz, your team at CMMI, your increasing collaborations with the rest of CMS and the rest of government and private sector, all are important steps along the way. Finally, before wrapping up and thanking, well, let me thank our panelists first for being with us for this great panel discussion. And before we wrap up today, as you probably can tell, this is a set of topics that is going to be front and center at Duke Margolis for the foreseeable future until we get to that simplified, widely adopted vision for a reformed healthcare system. So please stay in touch. We'll be doing a continuing series of events, activities, reports, papers, etc. And please collaborate. If you've heard something today that you want to follow up on, some things that we're missing, some opportunities that we aren't able to, or we haven't yet helped move forward and bring together in this general space, we'd really like to hear from you. Special thanks as well to the team at Duke Margolis that helped put this together: Luke, Patty, Hannah, Inga, Sarah, Rachel, Rob, and Frank. And special thanks to all of you joining us in the room and online today. You all are people who are doing this hard work every day, putting up with all the challenges because this work is so important. Thanks so much, and hope to see you all again soon. Safe travels back.